Okay, so first we have the classical conditioning. Okay, and classical conditioning happens when you got an involuntary response into something. Okay, so let us suppose you have a dog, and whenever dog sees the food, okay, the salivation occurs. Okay, now what happens is you do some changes, and along with the food, you started ringing the bell. Okay, now initially with the ringing of bell, the dog won't have any kind of salivation process. Okay, but as soon as he sees the food, he started having the salivation. Okay, you do that every day for weeks, and someday you just ring the bell without any food. And what happens is that dog, he started having salivation without even seeing the food, right? So a involuntary response is developed, okay, after some input, right? And you call that the classical conditioning, okay, that elicits the involuntary response. Okay, so learning in which a natural response, that means in this case, the salivation is elicited by the conditioned or a learned stimulus, okay, that was presented in conjunction with the unconditioned stimulus like the food. Okay, so you start ringing the bell with the food, and without the food even, the dog will have the salivation whenever he whenever you ring the bell, right? He started having the salivation. Whenever he hears the bell, he will have the salivation without even have any smell or sight of the food, right? So that was the classical conditioning. Any doubt?
No, thank you.
No, thank you.
Now you have the operant conditioning, and that elicits the voluntary response. One is the punishment, and second is the reinforcement. Okay, you call it a punishment, okay, whenever you want to decrease a behavior, and whenever you want to increase a desired behavior, you call it a reinforcement. Okay, now a punishment could be either a positive punishment in which you really gives a punishment like beating, right? Second type of punishment is removing a reward. Okay, so after giving a punishment, okay, if the patient decreases his undesired behavior, you call it a positive punishment. If by removing a reward, okay, if the patient is decreasing the behavior, you call it a negative punishment. Okay, second is the reinforcement, and with the reinforcement, you increases the desired behavior by giving the reward. If the patient is increasing the behavior, you call it a positive reinforcement. If by removing the punishment, the patient is increasing the desired behavior, you call it a negative reinforcement. Okay, for example, with the fear of getting punished, a student always completed his homework, right, with this fear. So he does the homework in order to avoid the punishment. So as you're removing the punishment, the patient is having a desired behavior, you call it a negative reinforcement. Similarly, you give some reward like a candy or something whenever they do their homework, you call it a positive reinforcement, right? Similarly, you have a punishment, positive, in which you really gives a punishment to decreases the undesired behavior, okay, and you removes a reward to decreases the undesired behavior. Any doubt?
No, thank you.
No.
So that was the operant conditioning. So classical conditioning is for the involuntary responses, and operant conditioning is for the voluntary responses. Okay. Now after this conditioning, the patient can also has the extinction. Okay. When you discontinue the reinforcement, okay, it will eventually eliminates the behavior. Okay, you stop giving them the reward. Ultimately, you will get a loss of that desired behavior in the patient, right? It can occur with both the classical conditioning and the operant conditioning. You started ringing the bell with the food, the dog will have the salivation with the bell. But as soon as he realizes that he's no longer getting the food with the bell, he will stop the salivation with the ringing of the bell, right? He won't respond to that ringing, and you call it that the extinction of the behavior, right? So removal of the reward will causes the extinction of the behavior, right? We call it the extinction. Any doubt?
No.
No.
Thank you.
Then you have two phenomena, the transference and the counter transference. Okay, transference occur whenever a patient project the feeling of another person onto the physician. Okay, for example, when a psychiatrist is seen as a parent to the patient, you call it the transference. That means a transference of the feelings, right? A transfer of the feelings, okay, from another person to the physician. Okay, you call it the transference. Similarly, you have the counter transference. Whenever the physician project the feeling of a third person, like a parent, okay, onto the this patient. Okay, that means, for example, the patient reminds the physician of a younger sibling, right? So this is known as the counter transference. Whenever after seeing a patient, it reminds him of someone else, his behavior, his physique, or anything, his dressing style, or anything. It reminds him of another person. Okay, either a sibling or a parent or anyone. You call it a counter transference. After seeing the physician, if patient remembers someone else, okay, you call it a transference. Okay, any doubt?
No.
Thank you.
Thank you.
And then you have the eco defenses. Okay, eco defenses basically it's kind of avoiding the real feelings, okay, in order to avoid the anxiety and the depression. Okay, patients uses every person uses all these ego defenses in order to avoid the real feelings, so that they won't get hurt, right? To avoid the anxiety, to avoid the depression, they uses all these kind of ego defenses. Okay, so the first one is the acting out. Okay, in that case, the patient always uses the action rather than the feelings. Okay, they will beat up, they will kind of fight. Okay, they will abuse, or indulge in any sexual activities. Okay, in order to avoid the real emotions, they will do anything. Okay, so that was the acting out. Okay, a patient skips the therapy appointments after a deep discomfort from dealing with his past. So uh, rather than facing the real feelings, he's avoiding by doing some kind of a action, any kind of action it was. Okay, either a fight, either a verbal abuse, or either skipping all the appointments, or anything it could be, right? So using the actions rather than the feelings, it is the acting out. Then you have the denial. Okay, and in that case, patient always in a denial kind of phase, right? They will always say that for example, you encounter a patient who is recently diagnosed with a cancer, a last stage cancer. So they will at the very initial, they will be in a denial that that cancer cannot be happened to them, and they're absolutely normal, nothing is happened to them, right? So you call it a denial behavior. Okay, they behave as the aspect of the reality does not exist, and it will even cause them a harm, because if you encounter a patient who is diagnosed with a with this the cancer, and if they're in the denial phase, then they will avoid the chemotherapy, right? They won't go into the chemotherapy, saying that they can that this cannot be true, that they cannot have the cancer. So they will avoid the chemotherapy, or they will do some activities that will worsen their conditions. Like for a diabetes patient, if you diagnose them with the diabetes and they will be in a denial, they will keep on adding these sweets or any sugars in their diet. So this will cause them harm, right? So that is the denial. Whenever the patient behave as if the aspect of the reality is not exist. Then you have the displacement, in which a patient displaces the feeling of one person onto the another. Okay, that means the redirection of the emotions or impulses to a neutral person or object. You call it the displacement, and this the patient done voluntarily. Okay, not involuntarily. Okay, this must be done voluntarily. For example, after being abandoned by the principal, a frustrated teacher returns home and criticizes her husband cooking instead of confronting the principal directly. Okay, so instead of saying her feelings to the principal directly, this teacher scolded her husband, right? instead of scolding the principal, because he cannot do with that principal, so he instead scolded the husband. Similarly, if you have if there is a boss in the company and he has some kind of a fight with his wife or someone, okay, and then they scolded all the receptionists instead of the wife or that person directly, you call them the displacement. Okay, so it's like displacing his anger onto someone else. Okay, then you have the dissociation, in which a person splits into two personalities sometimes. Okay, and you will see a dissociation later. We discuss it in very deep, and it always happen with a deep emotional trauma like a rape or any kind of seeing a near life and death experience. Okay, in that case the patient splits into two different personalities, right? And you call them the dissociation. Okay, a victim of a sexual abuse suddenly appears numb and detached whenever she is exposed to her abuser. Okay, so basically they split into two personality, different type of personalities, right? You call it a dissociation. It feel like the patient is outside of his body, right? Like they are a fog or they're in a dream or something like that. Like the things that are happening to them is not actually happening to them but a third person. Okay, so this is the dissociation. We will discuss about this in the later very deeply, so just know for this now. Any doubt on these four ego defenses?
I have one doubt.
Yes.
Acting out and displacement, they seem to be more or less similar.
No,
Because
on the acting out, you're displaying all these actions onto the same person even. But in the displacement, you cannot display your actions or your feelings to that person. Instead, you're displaying these feelings to another third person, right?
okay, yeah,
A non-hostile person, right? A neutral one,
right,
which is your junior. And if you're in case a superior person, always like a boss is scolding the receptionist, okay, or a teacher scolding the husband, because they can project their feeling on them and they cannot do about anything about that, right?
right, yeah. Thank you.
That is the main difference between the acting out and the displacement. Any more doubt?
No, thank you.
Oh, there's one page missing, I think. Just give me a second. Okay, now you have the fixation. Okay, when the patient are basically fixed on a particular development of the childhood, right? And when the patient fail to develop beyond a particular growth stage of the childhood, you call it the fixation. Okay, so in any adult, whenever you see any kind of a behavior that is seen in the children, you call it the fixation. For example, a surgeon throws a tantrum in the operating room, okay, tantrum in the operating room because the last case is very late. So the surgeon in this case is displaying a behavior which is generally seen in the children. So whenever you encounter this kind of a thing, for example, adult patient is sucking the thumb even in the adulthood, right? So whenever you encounter any of such case, whenever adult displaying any behavior of a child, you call it a fixation, because in that patient they fail to develop beyond a particular stage of the childhood, right? Then you have the idealization, okay, when the patient focus only the positive aspect of a certain incident, okay, they will remember only the good moments, not the bad moments. For example, um, about a trip, okay, if something bad happened with them on this trip and they remember only the good moments of the trip, not the bad moments, you call it a idealization. Like they ran into some kind of a accident or the trip got very flopped, but they remember only the good part about that trip, right? You call it the idealization. Okay, when a patient boasts about his physician and his accomplishments while ignoring any flaws, so you're not focusing any of the side effects or other negative sides of that person or that incident. You're focusing only on the positive aspects of that particular incident. You call it the idealization. Then you have the identification. Whenever a junior copies his senior, okay, whenever the patient copies anyone superior to them, you call it a identification. For example, whenever you see any movie, you started copying that hero, right, in some way, we call it the identification. Similarly, whenever a resident started copying their consultants, right, you call it the identification. Okay, whenever a child of an abusive father become abuser itself, you call it a identification. So in that case, a junior person is copying a senior person, right? You call it the identification, and it happens always unconsciously. Okay. Then you have the intellectualization. Whenever you focus on the scientific aspect of some incident, okay, you call it the intellectualization. For example, a patient who is diagnosed with the cancer, okay, and they just started talking about the pathophysiology of the disease or the epidemiology of the disease, rather than focusing on their own feelings. They're devastated by the diagnosis, but they're avoiding that feeling, the devastation, by focusing on the pathophysiology or the epidemiology, like that this cancer affects like 100 out of the 1000 patients, so it is very common with them, right? Also, so with some kind of a thoughts, these kind of thoughts are actually avoiding the real feelings. For example, a divorce case, okay, in which a patient is like focusing on the all these cases of the divorces, right, to avoid the feelings. Okay, so whenever a patient focuses on the scientific aspect or the epidemiological aspect of that incident, you call it the intellectualization. Okay, then you have the isolations. Okay, whenever a patient telling you any kind of incident without any emotion, when all the emotions which are associated with that incident are lost, you call it the isolation. Okay, whenever a patient describe a murder in graphic detail without any emotional response, like describing any sexual abuse without expressing any kind of sadness, so in that case the patient is not showing any kind of feeling associated with that incident. You call it the isolation of affect. Okay, then you have the passive aggression. Okay, when a patient expresses his feeling in a non-hostile way, instead of direct confronting that feeling, they started doing some things which will annoy that patient. Okay, so basically expressing the anger in the indirect way. Okay, rather than telling them directly their feelings. Okay, they're basically displaying their angerness or irritation with the some uncooperative way. Okay, for example, if a patient refuse to fill the form when they encounter that the physician is kind of running late, okay, so they won't fill up the form, and instead they say that that the doctor is very much intelligent, and they will get the history of the patient without any form or something like that. Okay, so basically they are displaying their feelings in a non-cooperative way by making the non-cooperation, right? You call it the passive aggression. Then you have the projection. Okay, in that case, this projection happens kind of involuntarily or unconsciously. Okay, okay. In that case, basically, you are displaying your feelings onto someone else. Okay, that the feelings that actually you are having on that person of that person, you are saying that that person is having those same feelings for you. Okay, for example, a man who wanted to cheat his wife accuses his wife of being cheatful or unfaithful, right? So in that case, uh, the feeling of that man is projecting these feelings on his wife or on third person. Like if you want to beat someone, okay, but instead you say that that third person is want to beat him instead of you, or you say that that same person wants to beat you instead you want to beat him, right? So basically you're projecting your feelings on someone else. You call it the projection. Then you have the rationalization. Okay, in that case, uh, they basically focus on the positive outcomes of a certain incident to avoid the feeling about that incident, to avoid the bad feeling about that incident. For example, a man who is recently fired from a job claims that a job was not important anyway, that they now can focus on someone as on something else, something more fruitful, right? So basically they are making excuses to avoid the self blame. They're making excuses so that they won't feel bad, right? So that is the rationalization. Whenever the patient think about the positive sides, or 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 making excuses to avoid the that sadness of that sadness feeling, right? That is the rationalization. Then you have the reaction formation, in which you are thinking something else but doing the opposite of it. For example, a stepmother, okay, who is very angry with the child or very sad having this stepchild, okay, she resents with the excessive nurturing and overprotection. So instead of confronting her feeling directly, okay, that they hate that child or something else, they instead become overprotective about that child. So thinking of something else and doing opposite of that feeling, right? You call it a reaction formation. Okay, a person expresses the anger in absolutely opposite manner instead of uh, directly confronting that feeling, right? Then you have the regression. Okay, in that case, the patient who is become matured not turned into the immature stage of his life after some incident. For example, a toilet trained child begin this bedwetting again following the birth of a sibling. So after an incident, if a person goes back to a previous unmature stage of their life, you call it a reaction formation. Sorry, you call it a regression. Okay, for example, a stressed adult watches a cartoon after some kind of an incident, right? You call it the regression. Then you have the repression. In that case, you are involuntarily holding the idea or the feeling, okay, from the conscious awareness. Okay, so basically in that case the patient is forgetting a memory that happened a long time ago to avoid the feeling of that memory. For example, a 20-year-old boy does not remember going into the counseling during the parents divorce 10 years ago. So basically they're forgetting a memory that happened a long time ago to avoid the feeling which is associated with that memory. Okay, so in that case always be a patient, and they're forgetting a memory that happens a long time ago, like 10 years or 15 years back. So they're basically forgetted that that thing happened with them at all, right, to avoid the feeling, and it happens totally involuntarily. Then you have the splitting. Okay, in that case, whenever patient encounter an incident of a certain patient, that patient become either the good or a completely bad person. Okay, for example, the patient stays a patient says that all the nurses are cold and intensive, but the doctors are warm and friendly. So in that case, all the doctors are good, all the nurses are bad. not in between. Either a person is a complete good or a person is a complete bad, according to that patient. Either all are positive or all are negative. Okay, it makes everyone a bad person or a complete good person in the patient's view. You call it the splitting. So for example, when a patient entered the hospital and they encounter the physician treated them badly, okay, very badly, and and they said that the physician is like a god or he's a very great person and blah blah blah. But on the time of discharge, the physician was not available for their discharge, and they again suddenly developed the feeling the physician is very bad and is careless. He does not care the patients at all. So in that case, the physician is either a very good person or a very bad person, not in between. You call it the splitting behavior, and this kind of a ego defense is very much common in the borderline personality disorder, and that is an important thing to take. Okay, either all are positive or all are a negative, not in between. So any doubt on the ego defenses so far?
Do we get very confusing questions in the main exam on these?
They will describe you a scenario of a certain patient. They will give you a perfect example of a certain patient. Okay, and after describing that scenario, they will ask you what kind of a ego defense is showing by the patient. So you need to identify that ego defense.
Yeah, okay. Like similar questions were there in UWorld also.
Yeah, exactly. Like these examples, they will give you such example, anything like these scenarios, these situations. And after describing that situation, they will ask you what kind of a ego defense the patient is displaying, right?
Okay, yeah.
So for that, you need to make sure that you know all these defenses very well. Okay.
Yeah, thank you.
After you encounter one or two examples, you will know how these defenses look like. So don't worry about that. Just one or two questions are enough on these ego defenses.
Okay, thank you.
Then you have the mature defenses, okay, which are actually beneficial ones. All the immature ones we have discussed, they are actually non-beneficial ones. Okay. So for the mature defenses, you have first the sublimation. Okay. In that case, a patient sublimate their behavior, okay, or their feeling onto something fruitful. For example, a teenage patient, okay, who is very aggression, or who is having a very high aggression towards his parents, he become a boxer, for example. If a patient who is very angry, he becomes a boxer. So in that case, the patient sublimated his behavior onto something fruitful, right? You call it the sublimation. Whenever the patient uses a negative emotion in a positive way, you call it the sublimation. Then you have the altruism, okay, in which a negative person now recently suddenly started showing the sympathies or large donations or charities. Like for example, a mafia boss makes a large donation to a charity, right? So in that case, the patient is elevating a negative feeling via generosity or providing the gratification. For example, a patient who is having a cancer now, he's gonna die. Okay, so in order to avoid that feeling, he started making the charity suddenly, right? So you call it the altruism. It is a practice of concern for others. Okay, like charity, donations, generosity, gratification, anything it could be. Okay, and it is very much different than the reaction formation. What was happening in the reaction formation?
The same energy was being transferred onto something else.
In case of reaction formation, you're doing opposite to what you're thinking,
thing.
right? But in case of my altruism, you're basically doing the generosities. All these eco defenses, these mature defenses are basically beneficial to the society, right? Think about it. Like a sublimation is beneficial to society. Altruism, it is again a beneficial to society because they're helping others with their feelings, right? Okay. Okay. So now comes the suppression, in which a patient knowingly or voluntarily suppresses the negative feeling to avoid the sadness. Okay, it is almost different from that of the repression, right? In case of a repression, you are suppressing the feelings involuntarily, right?
Yes.
Yeah.
In case of my suppression, you are withholding the idea or suppressing the feeling voluntarily. Okay, that after, for example, your USMLE exam, okay, you got very afraid, or and so you just decided to not to think about that exam. Okay, just focus on the positive sides, that now the exam is over, and on the exam day you will sorry, and on the result day you will face whatever happened, right? So they're suppressing the negative feeling. Okay, and that is known as the suppressing. Then you have the humor, and everyone know what a humor is, right? You make jokes or any kind of a thing, okay, in order to avoid the this negative feeling or that fear, right? You call it the humor. So any doubt on any of the four?
No, thank you.
No, thank you.
So that was about your mature and the immature ego defenses. All of these defenses are to basically to avoid that negative feeling, okay, or that depression or anxiety, right? So that was it. Any doubt on these, any of the ego defenses, please ask.
No, thank you.
Okay, just give me a second again. Okay, now comes the infant deprivation effects. Okay, whenever you do not give any care, any love, anything to a child, okay, what will happen to them is the infant deprivation effects. Okay, with a long-term deprivation of any kind of affection like love, care, comfort, okay, the patient, the child will have a failure to thrive. They will have a low mass, they will have a low BMI, low weight, they will become very malnourished type. They have a very poor languages and socializing skills. Okay, they basically lack a basic trust on anyone. Okay, they will have either very kind of attachment to the strangers, or they become socially isolated completely. Okay, they will become very withdrawn or unresponsive to the comfort. Whenever someone try to give them the comfort, they cannot show any kind of a feeling for them, right? So basically, they are inhibited. They do not show any kind of emotions. They either can become socially detached, or they become too much engaged with the strangers. They started hugging their strangers. Okay, so it is kind of a opposite to the reactive attachment disorder, right? In that case, the patient become very too much affectionate or attached with the strangers. But in case of your RAD, you'll become detached with the socialization, right? You become socially isolated whenever a child does not get any love, care, or any discomfort. Okay, and a deprivation for more than 6 months can lead to the irreversible changes. In that case, the patient can also get the severe deprivation, and in that case, the patient can get a death also. Okay, any doubt?
No, thank you.
Then you have different type of child abuses. One is the physical abuse, second is the sexual abuse, and third is the emotional abuse. The signs of the physical abuse includes all the shaken baby syndrome. Remember,
Yes.
you will have a epidural or a subdural hemorrhage. If anyone remember,
Subdural.
yeah, you will have a subdural hemorrhage. You will have a retinal hemorrhages. You will have a broken ribs. Okay, the patient can have any broken arm. Okay, and all the parents, they will describe an incident which is kind of unrelated to that injury. That incident cannot cause that kind of injury. They will describe that in kind of incident, and that's how you know, because the given incident is not matching with the kind of injury. That means the patient is lying, right? And the patient is basically the parent is lying, and that means the patient is having a child abuse. Okay, the caregivers always delay seeking the medical attention of the child, or provide the explanations or the incidents which are inconsistent with the child's stage or the pattern of the injury. Like they tell the bruises are due to the fall, or they get the this subdural hemorrhage after a certain fall from the bed. So they will give you always a inconsistent type of histories of that incident, right? And most oftenly, in case of a physical abuse, the parents are single parent. Okay, the patient can have a burn of cigarette burn marks. Okay, so something like that will happen. Then you have the sexual abuse. In that case, the signs are the sexually transmitted infections, UTIs, genital or anal or any kind of a oral trauma can happen to the patient. Okay, so whenever you encounter a patient having any kind of a sexual symptom, a teen patient, okay, or a pupil or a pre-puberty patient having any kind of a sexual symptom like a UTI, STD, or any kind of a genital or anal trauma, think about the sexual abuse. Okay, and it is most commonly done by a male, okay, who is known to that child, a very close person to that child. Okay, then you have the emotional abuse, and that can happen with the infant deprivation syndrome. Okay, it is a kind of emotional abuse to the patient, right? They will have a lack of bond with the caregiver. Okay, and but they become very much affectionate with the strangers, like we have discussed. They will start hugging the strangers. Okay, opposite to that of RAD. Okay, they have maybe the anger outburst sometimes. Okay, and they will distance themselves from the caregivers and other children also. Okay, so that was about the physical abuse, sexual abuse, and emotional abuse. So for the emotional abuse, think about the infant deprivation effects. Sexual abuse, think about any kind of injury or any kind of signs and symptoms uh, with this thing. Okay, and then you have the physical abuse. In that case, remember the shaken baby syndrome. You will have a subdural hematomas. You will have retinal hemorrhages. You will have any kind of a fracture in the rib, in the arms, and they will give you some kind of a history which is inconsistent with the physical findings on the patient. Right? Any doubt?
No.
No, thank you.
Then you have the epidemiology, which is the 40% of deaths related to a child abuse or neglect occur in the children less than 1 year old. They can ask you this same fact. Okay, so remember 40%, 1 year old. Okay, the peak incident is between the 9 to 12 years, which we had discussed already. The patient will always be a pre-puberty child. Okay, and 80% of the young adult victims, okay, who are basically having a child abuse, they will have any of the psychiatric condition, at least one psychiatric condition, okay, by the age of 21. And that is important also. They will ask you this 80% thing, and they will ask you this age also, right? So remember, whenever you encounter a patient having having an emotional abuse, very high chances, or you can say 80% chances, that they will have any kind of a psychiatric disorder by the age of 21. Any doubt on child abuse?
No, thank you.
Then you have a child neglect. You call it a child neglect whenever the caregivers cannot provide the adequate food, shelter, supervision, education, or affection to the children. Okay. Signs and symptoms include all this. Infant deprivation effects would be there. They will become socially isolated or become too much affectionate with the strangers. Right? They have this poor socialization skills, poor verbal skills, failure to thrive will be there, poor hygiene will be there, malnutrition will be there, withdrawal will be there. Right? So these are all the symptoms of the child neglect. Okay, and the child neglect must be reported to the child protective services whenever you encounter a child who is having a failure to thrive, or he is very much kind of isolated with the surroundings, having a poor hygiene, okay, and withdrawal. He cannot make the eye contact with you, right? So think about the child neglect in that case. Then comes the vulnerable child syndrome, when the patient, or you can say the parent, become too much sensitive or overprotective for their child. Like even if they got a small cut in their finger, they will bring that patient to the, they will bring that child to the hospital, thinking about something more severe. Okay, so you call it a vulnerable child syndrome. Okay, whenever the parents perceive the child as especially susceptible to the illness or the injury, it can result in the missed schools or overuse of the medical services. So with even a small injury, they will admit they will admit their child, right? So that is the vulnerable child syndrome. Risk factors: it would be a parents with a difficulty in the conception, and after a lots of effort they got their child. Okay, if they have a very difficult kind of pregnancy, Okay, if the parents have any kind of a anxiety or any kind of a depression, they will become very much overprotective. You call it a vulnerable child syndrome. Any doubt?
I have one question.
Yes.
What's the difference between child neglect and infant deprivation syndrome?
Infant deprivation syndrome can happen because of the child neglect.
Okay.
It is kind of a cause of that infant deprivation syndrome, you can say. Okay.
Oh, yeah. Okay. Thank you.
Yeah. So, any more doubt on this page?
No.
Then you have the childhood early onset disorders. Okay. And please note, it would take time for a child to develop their behavior. Okay. And I think it's almost around 6 or 7 months, okay, till they develop their behavior. Okay, because up to the you can say 5 years, not the 6 months, but up to the 5 years, okay, the patient is still developing their behavior. Okay, they're still in a developmental stage. So none of the disorder, okay, can be diagnosed before the 5 years, and that is the important thing. The patient always gonna be a case of more than 5-year-old patient. Okay, if you guys go forward to the reproduction chapter, you will discuss all the infant and child developmental stages, right? All the social, motor, and the verbal skills, right?
Yeah.
Yes.
And you see that up to the 5 years, they are still developing their motor, social, and the verbal skills. So after 5 years only, when they have developed their skills, okay, social, motor, and verbal, only then you can diagnose them with any of this disorder, not before 5 years. So the first one is the attention deficit hyperactivity disorder, and as the name suggests, you're gonna have an attention deficit, okay, loss of attention, and hyperactivity in the child. Okay, it is generally seen in the children of age between 6 to 12 years. Symptoms must be more than of 6 months, and it must be in more than two surroundings, two settings, like the school and home, or a school or worship place, or home at worship or this worship place. Okay, they will have a symptoms of the attention deficit. Okay, they will have this loss of focus. Okay, something like that. They will have history of misplacing the objects. Okay, forgetting the way of home. Okay, so they will have a history of the attention deficit, and they have a history of the hyperactivity. Okay, they will have a very poor impulse control. Okay, they walk in the class, they shout in the class. Okay, they smile, and they basically disturb the class with their hyperactivity. So any of the symptom of the attention deficit, like the forgetfulness or inattention, okay, forget their books or utensils, right? Difficulty in focusing, distractible, okay, and the symptoms of the hyperactivity, okay, think about the ADHD, okay, and please know that it must be in more than two settings: school or home, school or worship place, home and worship place, any could be, okay, and the patient must be between 6 to 12 years old. Okay, any doubts so far?
No, thank you.
This disorder commonly exists with the oppositional defiant disorder. We will discuss that later, what the disorder is. Just know that this could be associated with the ODD. Okay, and the treatment includes giving the patient stimulants like the methylphenidate. It will increases the dopamine. Okay, and you can also give the patient alpha 2 receptor agonists. Okay, like the clonidine. So the guanfacine, the clonidine, okay, the methylphenidate, atomoxetine, and this is an important drug. Atomoxetine is a non-methylphenidate drug. It will also increases the concentration of dopamine. It has low side effects, and as well as uh, uh, it has low dependence also. So atomoxetine is a very important drugs. Okay, so methylphenidate, atomoxetine, guanfacine, clonidine. These are all are the treatment for the ADHD. Okay, any doubt?
No, thank you.
Okay. note that diagnosis cannot be made before the age of 4 to 5 years, because kids before 4 to 5 years old, they can present with the similar symptoms. Okay, but it is actually totally normal because they're still in the developmental stage. They're still developing their behavior. So, all this ADHD is normal before 4 to 5 years. They will have a loss of attention. They will have a very hyperactivity before age of 5 years, but not after 5 or 6 years later. Now, second, you have the autism spectrum disorder, and that is the only disorder, along with one more. Okay, and it could be diagnosed by the age of 2 years. Okay, because in that disorder, the patient having a very poor socialization skills. They have a very poor social and communication skills. Deficits are there. Okay, they will remove themselves. Patient will remove themselves from the social interaction. They will have a speech delay. Okay, they will have a repetitive play. Okay, they will always insist on the sameness. They always want the same schedule. They always want the same toy, same thing at same time. Okay, so basically insist on the sameness always. They have a restricted interests. They can have intellectual disability, or they can have above average abilities. Like they can have a very specific skills, like they become a super great musician. Okay, or something like that. Okay, so that was the autism spectrum disorder. So a patient who is having a very poor social interaction, they basically sit in the corner. Okay, and they keep everything to themselves only. Okay, they always insist on the sameness. They always want to sit on the same bench in the school. They want the same pen. Okay, they always want the sameness in their life. That is about the autism spectrum disorder, and it, please note, it will be diagnosed by the age of 2 years. Okay, any doubt?
No, thank you.
No, thank you.
Then you have the conduct disorder. Okay, just give me a second. Okay, so let's discuss the conduct disorder. Okay, a portion defined disorder. Okay, together. So just give me a second. Yeah. So let's discuss the conduct disorder and the apportion defined disorder. In the conduct disorder, the patient is having a very aggression in them. Okay, they have a very kind of activities which is inconsistent with the social norms. Okay, they will always break the law. They will involve in the criminal activities. Okay, like firing, or like breaking, like failing the brakes. Okay, they always want to take the revenge from others. They will destroy the properties. Okay, they will become a theft. Okay, and they will have this aggression towards the animals or towards the other people. Okay, and they do not show any kind of a remorse with the others condition. Okay, they have no feelings, no pityness for the others. Okay, so they will have lying. They will have activities like the stealing. Okay, so they're basically involved in the criminal activities. After the age of 18, you call this the antisocial personality disorder. So before the age of 18, it is the conduct disorder, and after the age of 18, you call it the antisocial personality disorder. Whenever you see a patient who is indulged in some kind of a criminal activities, they're having the aggression, okay, towards other, they break the laws. Okay, they are involved in the criminal activities, they destroy the property. Okay, they teases the animals, right? They steal something, they lie, right? Think about the conduct disorder. Then you have the opposition defined disorder, in which the patient, similar to my conduct disorder, they are very angry, irritable. Okay, just like my conduct disorder, they can be very much argumentative. Okay, they will always blame others for their behavior. Okay, just like my conduct disorder. Okay, they will always defy the behaviors towards the authority figures. Okay, they do not follow their rules. They always want to cross their boundaries. So all these symptoms of the opposition defined disorder are kind of very much similar to that of conduct disorder. So how can you differentiate between the conduct disorder and the opposition defined disorder? Anyone?
No damage to the other person's property or anything.
Yeah.
Yeah, not involvement, no involvement in the criminal activities is what differentiate between the conduct disorder and the opposition defined disorder. If you anytime encounter a patient who is involved in the criminal activities, which you might feel the patient should be in the jail for, think about the conduct disorder. If you feel like the patient is having some features of the conduct disorder, but they hasn't done anything which can make him go to the jail, think about the opposition defined disorder. Let's discuss in more deeply. You will have four symptoms majorly. One is the angry or the irritable behavior. They have a very frequent anger outbursts. Okay, they will be easily annoyed and they often loses their temper. Okay, so so basically they become very much angry or aggressive. Second is the argumentative or the defined behavior. They do not follow the rules. They will become very much argumentative. They argue with any of the authority figures like the teachers, parents. Okay, they will deliberately annoy others like the siblings. Okay, they will blame others for their mistakes, and they have the vindictive behavior, which means revenge seeking behavior. They always seek revenge from others. So these four, okay, are the features of the opposition defined disorder. Along with these four features, if they're involved in the criminal activity, also think about the conduct disorder. If the patient only has the angry or the irritable behavior, not other three, think about the disruptive mood, dysregulation disorder, in which the patient is having a very angry mood always. They will become very much irritable. They have the these anger outbursts. Okay, so only the first feature of the oppositional defined disorder is present in the disruptive mood dysregulation disorder. And along with these four features, if you also have a criminal activity, think about the conduct disorder. If you have any of the only of these four features, okay, without any other association, think about the opposition defined disorder. Is that okay?
Yes.
So that was the conduct disorder, disruptive mood dysregulation disorder, and the opposition defined disorder. Then you have the intellectual disability, and you already know that you will have the defect in the cognitive this ability of the patient. Okay, it could be specific. Specific means whenever the patient have any any kind of a disability only in one situation. Okay, like they cannot write properly, they cannot read properly. Okay, or they cannot speak properly. Whenever they have this kind of disability only in one scenario. Okay, or sometimes they can have this the defect globally, like the thinking, judgment, language, learning, adaptation, anything. Like if the multiple if in case of multiple areas involved, think about the global one. Okay, or you can have a specific learning disorder if only you have a defect in the deficit only in the one situation or one scenario, like the patient cannot read properly, or they cannot write properly, or they cannot speak properly. Okay, so if only one disorder is present, think about the specific learning disorder. If multiple defects are present, deficits are present, think about the intellectual disability. And whenever you encounter a patient with the intellectual disability, you need to make sure that they do not have any hearing impairment, they do not have any eyesight weakness, okay, or they do not have any kind of a damage with their mouth or their brain. After you eliminate all these causes, then you will go for the intellectual disability or the specific learning disorder. Okay.
Could you please explain the difference between global and specific once again?
In case of specific, as the name suggests, the patient will have a disorder, a learning disorder, only at a one specific scenario. Like they cannot speak, or they cannot write, or they cannot speak a particular language like the English, for example, right? Or they cannot write properly. They have a very poor handwriting. Okay, or they cannot do the maths, right? Or they cannot speak properly. So only in the one scenario they're having a difficulty. Think about the specific learning disorder. If you have the defects in the multiple scenarios, okay, like the thinking, judgment, language, learning at the same time, then you think about the intellectual disabilities, and you already know many causes of the intellectual disability, right? Like the Down syndromes, Fragile X syndrome, right?
Yeah.
So that is a huge difference between these two. Now,
Oh,
any doubt?
No.
Could you differentiate disruptive mode dysregulation disorder and opposition defiant disorder one more time, please?
See, in case of opposition defiant disorder, you're going to have 4 symptoms. Okay. One is the aggressiveness and the irritability. The patient will become very much aggressive. They have the anger outburst. Okay. They will become irritable with a very, with a very small situation. They often loses their temper. Okay. Second thing is the argumentative behavior. Okay. They will become very much argumentative. They always argue with their seniors, with the authority figures like the parents, teachers, right? They have this uh, 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 they have they will always annoy others. Okay, they will blame others for their mistakes. Okay, and they have the vindictive behavior. Okay, which means the revenge seeking behavior. So these 4 features are present in the opposition defiant disorder, but only one feature is present in the disruptive mood dysregulation disorder, which means they have become very much irritable and angry. They often loses their temper. Okay, they have this they would and they will get very annoyed easily. So only the first feature of the opposition defiant disorder is present in the disruptive mood dysregulation disorder, right?
Okay, got it. Thank you. Yeah. Yes, got it. Thank you.
Okay. Then you have the selective mutism. Okay, and it onsets before the age of 5. Okay, whenever the patient is having an anxiety disorder in a very specific situation, the patient is although absolutely normal, but in a specific situation the patient got an anxiety. Okay, and you call it the selective mutism. That means in a very selective situation the patient got mute, they cannot speak, they got sweating, or they got something like that. Okay, in a very specific situation only. So anxiety disorder lasting for more than 1 month, in which the patient is refraining from speech in a certain situation only. Okay, they can speak properly at home. Okay, fluency with the fluency. Okay, they can sing at home, they can run at home, they can do anything, any activity at home. Okay, but in a very specific situation like on a stage, okay, they cannot say a word, they become very much muted. Okay, so you call it a selective mutism. Okay, it interferes with the social, academic, and the occupational tasks of the patient, because in these scenarios, in these situations, the patient cannot do their activity properly, right? It generally coexists with the social anxiety disorder also. Okay, any doubt on the selective mutism?
No, thank you. No.
Okay, now you have the separation anxiety disorder. As the name suggests, the patient will have an anxiety with the separation. Okay, okay, so it is basically the overwhelming fear of the separation from the home. Okay, whenever the patient got a thought of separating from home or going away from the home, they started having the symptoms. Okay, they can have the abdominal pain. Okay, they can have a nausea, vomiting whenever they think about getting away from the home, like going to school even. Okay, they will have nightmares which are associated with the separation from the parents. Okay, so they will have thoughts, they will have fears, they will have all these dreams, nightmares which are associated with the separation from the home or the parents, right? You call it a separation anxiety disorder. A child who is who is less than 5 years of age, they have this normal behavior. And you will study in the repertory section where we discuss about all these developmental milestones. Then the that every child up to the 5 years, they have a normal separation anxiety, right? It is normal. But after 4 or 5 years, when the patient got a separation anxiety, you call it a separation anxiety disorder. Whenever they got away from their parents or their home, they started having this anxiety. They're having this all the all these symptoms like the abdominal pain. Physical symptoms would be there, right? So nightmares will be there. Physical symptoms like the headache, nausea, vomiting. Okay, whenever they got a thought of separation, they will have that, right? So that is the separation anxiety disorder. Any doubt?
No, thank you.
No, thank you.
And please note that these physical symptoms, headache, nausea, stomachache, they can be factitious to avoid getting away from the home. For example, a child do not want to get away from the home, like they do not want to get go school, right? So basically, they make their symptoms like the stomach pain or the headache to avoid going to the school, to avoid going away from the home, right? So they will deliberately induces the symptom sometimes. Okay, so a factitiousness can be also present in my separation anxiety disorder, right? So whenever I encounter a child who always, with a thought of going to the school, he started having this stomach ache or the headache. Okay, but with the playing, he got absolutely normal whenever he plays. So that's how you know that a patient is basically inducing their symptoms deliberately. They are basically getting a factitiousness, right?
Yes.
Then you have a specific learning disorder, which we have discussed already. Okay. Whenever the patient have a learning disorder in a specific subject or in a specific situation, like in the maths, or maybe in a reading, maybe in a writing, maybe in a speaking, in a very particular scenario, they will have the deficit in the learning. We call it a specific learning disorder. Okay. And generally, all the functionings and the intelligence of the patient must be normal. Okay, which is not the case with the intellectual disability. Okay, you need to rule out the intellectual disability. You need to rule out all the hearing disorder, vision loss, or any other psychiatric disorder before diagnosing the patient with the specific learning disorder, right? You need to make sure that the patient is not deaf, the patient is not blind, they can see properly and anything before going to the specific learning disorder, right?
Yeah.
Then you have the Tourette syndrome, in which you get the tics. It could be a motor tic, it could be a verbal tic, it could be anything. Okay, any repetitive movement patient will get, you call it a Tourette syndrome. It is similar to that of chorea. Like I told you, sometimes patient can, the treatment of the head in chorea, remember? Tetrabenazine.
Tetraben.
I told you that, the tetrabenazine can also be used for the Tourette syndrome, right?
Yeah.
Yes.
So in the case of my Tourette syndrome, you will have tics. It could be a motor tic. They will have the chorea-like movement. They will have facial grimacing. They will have repeated blinking of the eye. They will have a head movement. They will have a shoulder shrugging. It could be a verbal tic. They will make the grunting sound. They will cough regularly. Okay. They will have this sniffling movement of their nose. So it could be anything, any kind of a repetitive movement. Okay, the patient will get. You call it a Tourette syndrome. It happens before the age of 18. A sudden non-rhythmic stereotype motor or the vocal tics happen in the patient for more than 1 year, and this condition is generally associated with the ADHD and the obsessive compulsive disorder. Treatment include the behavioral therapy, okay, high potency antipsychotics, tetrabenazine, which will destroy the VMATs, alpha 2 agonists like the gonfacine, clonidine. Okay, so these are the drugs for the Tourette syndrome. Any doubt?
No, thank you.
So whenever you encounter any patient having a repetitive movements, think about that. Yeah, and do not confuse it with the autism spectrum disorder, because in case of my autism spectrum, you can have the repetitive movements again, right? But they are not the Tourette syndrome. In Tourette syndrome, you can have a multiple type of movements with a normal socializing person. In case of my autism, you can have a single repetitive movement, okay, like the clapping always, but they do not have any kind of a social interaction, right? And that is a huge key finding in the autism, which is not present in Tourette. Okay.
Yes.
Okay. So that was about all of my childhood and early onset disorders. Please note, all these disorders are only diagnosed after the age of 5 years, because before 5 years, the patient is still in the developmental milestones, right? And so it is, all these conditions are normal in a child less than 5 years, except for the autism, which is diagnosed by the age of 2 years. Okay.
Yes.
Any doubt on any of this disease, please ask.
No, thank you.
No, thank you.
Okay, so we will take a short break and then start with the orientation.
Yes.
Okay.
Yes.
I've never watched Big Bang Theory, sorry, so I don't know who the Raj is.
Yeah, okay, no problem.
Okay, so now let's discuss the orientation. When you call a person that he's fully oriented, okay, whenever you know what his name is, okay, he know the person, he know the place where he's at, okay, and he know the times. Okay, so whenever a person have a fully orientation with the time, place, and person, you call it a fully oriented person. Okay, disorientation happening whenever they do not know the time, place, or person they are, right? It can happen with the alcohol, with the drugs, with the electrolyte imbalance like the SIADH or the AD or the diabetes insipidus sometimes. Any head trauma can cause it, hypoglycemia, infection, nutritional deficiencies, hypoxia, okay, delirium, dementia, all of them are the causes of the disorientation. Okay, and you always need to ask the time with the patient, the place where they are at, okay, and the name of the patient. If they describe you all these three, you call it a oriented person. If they cannot describe you these three, you call it a disoriented person. And it out. I think it's simple.
No, thank you.
Okay. Now you have the amnesias. Okay, that means a loss of memory. You call it a dementia whenever you have amnesia along with a cognitive decline, right? And whenever you just only have a memory loss, you call it a amnesia. First, you have the retrograde amnesia. That means you will lose all the memories which are associated before the event. Okay, like all these, all the long-term memories that the patient has, the name of the family members, where they live, or anything about that, anything a distant memory they will forget after the incident occur. Okay, you call it a retrograde amnesia. Incident can be an emotional trauma, it could be any physical trauma or anything like that. Okay, so after that trauma happened, after that incident happened, before that incident, when the patient loses all of the memories which are associated, you call it a retrograde amnesia. They can still make new memories, okay, but they forget everything about their past. Second, they have the anterograde amnesia, and in that case, they will forget all these memories that happened after all these incident or events that happened after the incident, after that CNS insult, right? So they cannot remember anything after that incident, right? So it is known as the anterograde amnesia. Then you have the Korsakoff syndrome. If you guys remember thiamine deficiency, the Wernicke-Korsakoff syndrome. In the Wernicke's encephalopathy, you will be having the nystagmus, ataxia, and in the Korsakoff syndrome, you will be having a loss of memory. Initially, you will have an anterograde amnesia. You will forget all the memories after the loss of thiamine or the alcoholism. Okay, then you have the retrograde amnesia, right? You will have a loss of memories which are distant to your past, right? And often the memories loss are irreversible in case of my Korsakoff syndrome, right? And the patient will also become disoriented. It will happen with the thiamine deficiency, right? Because of the memory body's dysfunction and damage, and the limbic system damage occurs, right? It generally associated with the Wernicke's encephalopathy also, and we call it a Wernicke's-Korsakoff syndrome, right? And confabulations are also there. In order to fill that memory gap, okay, the patient will start telling you anything, okay, like they meet a unicorn or they met a fairy that take into their memories or something like that. So they will what they will make their what will make the incident or their memories, right, to fill the memory gaps. Okay, they will tell you anything to fill that memory gaps, right? So this is the confabulations. So these are things happens with the Korsakoff syndrome. Any doubt?
No, thank you.
No, thank you.
And now you have the dissociative disorders. Okay, all these disorders happen after some kind of emotional trauma or a psychological trauma, I must say, like a sexual abuse, okay, or an attack. Okay, so all this happens, or after a loss of someone the patient loves. Okay, after a breakup, maybe. Okay, so all these conditions are associated with some kind of a psychological trauma. Okay, the first one is the depersonalization, derealization disorder, in which the patient has a detachment from their own body. Okay, they will feel like they're outside their body and they're seeing their body from their eyes, being outside their bodies, right? They they will think that their thoughts are not their thoughts. Okay, they will have a different perception and actions about the reality. They will feel like they're in a fog. or everything is happening like a dream. Everything is like a dream. Okay, so that is the depersonalization and derealization disorder. When the patient tell you that they often feel like they're detached from their body, like they're outside from their body, and anything happened to them is actually not happening with them but with someone else, like they are a fog or they are in a dream or something like that. Think about the depersonalization derealization disorder. And in that case, please note, you need to differentiate it with the psychosis. And the way by which you can do is by testing the reality, intact reality testing. If the patient has an insight that what's happening to them is not real, okay, it's their imagination or something wrong with them, then you call it a depersonalization derealization disorder. If they do not have any insight on their condition, if they whatever they are feeling, if they feel like it is real, okay, then you call it a psychosis. If they believe on all these things, you call it a psychosis. If the individual feel like all the detachment, but they know but they know that this condition is not true, this is not happening with them, you call it a depersonalization derealization disorder. Okay, any doubt?
No, thank you.
No, thank you.
Okay, then you have the dissociative amnesia. Okay, when the patient is unable to recall a past experience, in that case the patient is having a retrograde amnesia after that emotional trauma. Okay, like like any kind of a accident or any kind of a sexual abuse or any kind of a death of a loved one or something like that. So after that psychological trauma, patient cannot recall any distant memory. They will forget their name, they will forget where they live, okay, who their family members are, they will forget everything about their past. Okay, and as a result, sometimes when this condition become very much severe, they will have a dissociative fugue. In that case, the patient travel away from the home, they got a new identity, they start working in the new town as a new identity, they forget everything about their past. Okay, you call it a dissociative fugue. Okay, so in that case, they are unaware of their past, and they don't bother of their memory, they don't focus, they don't have any problem with their loss, because they do not know if anything happened with them previously, right? So they do not have any kind of insight of their memories loss. Okay, so this condition do not bother the patient, they just get a new identity and start working on the new town. Okay, so the patient will go missing. Okay, and maybe they are found in the other state working under different name, under different job. This is the dissociative fugue. It happens after the dissociative amnesia. Okay, then you have the dissociative identity disorder. It is also known as the multiple personality disorder, in which the patient memory splits into two. Okay, at one time they behave like another person, and at another time they behave like another person. Okay, so they have a two distinct memory, and sometimes, okay, while behaving like another person, they even can commit a murder. Okay, they may commit murder in a different personality state. Okay, you call it a dissociative identity disorder or a multiple personality disorder. Okay, it can be happen with a patient with a sexual abuse. Okay, it generally associated with the PTSD, depression, and when this condition is associated with the PTSD, you won't call it a dissociative identity disorder, but you call it a PTSD instead. Okay, this could be a symptom of the PTSD, so you cannot diagnose it um, alone. You have to diagnose it with the PTSD as the PTSD symptom, right? So that is the important thing. So before diagnosing the patient with the dissociative identity disorder, you need to make sure that he's not having any symptom of the PTSD or a depression. If they have any symptom of depression or a PTSD, you cannot call it a dissociative identity disorder. You need to call it PTSD or depression itself. Okay, any doubt?
No, thank you.
No, thank you.
Okay. So that was everything about my dissociative disorders. Okay. Then you have the delirium. And please note, the case of a delirium is always going to be a hospitalized patient. Okay, it would be a patient, okay, who is admitted to your hospital under a normal condition. They got some kind of an infection or some kind of a history, but they're absolutely normal before the admission. After the admission, they started having these psychotic episodes. And I'm telling you, episodes. because at one time they will be absolutely normal, okay, and in one time they loses all their consciousness, they got the psychotic episodes, right? This condition is very much acute. It happens suddenly, like 1 day before or an hour before the patient was absolutely normal, and then suddenly after an hour later they started having this psychosis and altered consciousness. We call it a delirium. It is always seen in the hospitalized patients. Okay, it is a waxing waning level of consciousness. In this case, that patient at one time have a normal orientation, they will become very much alert, attentive, and then again after 5 minutes later, they again become very much disoriented. They lost the consciousness. Okay, so it is a waxing waning level of consciousness, and because their orientation is waxing and waning, it will be very much difficult for the physician or the nurse to take the history of the patient. Okay, they will have a decreased level of the arousal, they will have a decreased attention, and that makes very hard to take the history of the patient. Okay, they will have the psychotic episodes like the hallucinations, we call it, and the hallucinations are often visual. They may see their dead brother or their dead wife. They may start talking to their dead wife. Okay, they have a misperceptions. They can accuse the nurse or the or any staff, okay, for a thief or stealing some of their object, right? So they have the misperception. Okay, they have a disturbance in the sleep wake cycle. Okay, they will sleep in during the daytime and wake up at the night, and that is the most common feature you will get. They will have all these psychotic episodes, all these deliriums in the night time, not in the daytime. Okay, and yeah, so they will also have a cognitive dysfunction. So please note, all these conditions are acute in nature rather than the chronic that happens with the dementia or any other psychosis, right? Secondly, these all conditions, the delirium is always present with the any kind of a infectable, any kind of a identifiable illness like a CNS disease, maybe like the meningitis. It could be happen with the infection like the UTI even can cause it. It can happen with the trauma, any kind of. It can happen with a withdrawal of certain drugs. Certain drug withdrawals are associated with the delirium. Okay, it can happen because of the electrolyte disbalances, any kind of a medications, mostly the anticholinergics can cause it. So please note, patient will always have some kind of a history of any infection or any drug or any metabolic changes like the ascites even. So any kind of a disease with a hospitalized patient can cause this delirium. Okay, the patient will be having episodic orientation and disorientation. They will, and whenever they become oriented, they will started having all this shouting and aggressiveness. They will uh, and they will think that the staffs are stealing something from them. They will accuse the staffs of the stealing or the theft, right? So all these symptoms are in the history of the patient are present. Okay, so the most common presentation, it will be the altered mental status in the inpatient setting, especially in the ICU or during the prolonged stay in the hospitals. Okay, EEG may also show some kind of a rhythm slowing movements that you don't need to know. Okay, it is a core psychiatry stuff. So just know, the EEG is kind of abnormal in delirium, but normal in my dementia or any other disorder. Because in my dementia, I can have these kind of things. Okay, but all these things are very much progressive in the nature, and they are chronic in the nature rather than my delirium, which is episodic and acute, right? So whenever you got a patient with a delirium in the hospital, you always need to check the orientation. Okay, you will keep a clock or a calendar nearby. You will always ask them about their name, place, and person, the name, place, and time, right? And they will have a decrease in the sleep disturbances. In the treatment, it will decrease the sleep disturbances and increase the cognitive stimulations. And please note, you will need the antipsychotic therapy to control the delirium, and you use the haloperidol for that. And that's why the haloperidol is also known as the vitamin H. Okay, so please note, for the treatment of delirium, you will use the vitamin H or the haloperidol, and you must avoid any agent, okay, that can worsen the delirium, any kind of a sedative like the anticholinergic, benzodiazepines, or any opioid. They all are contraindicated whenever you got a patient with delirium. Okay, and it is a very common cause of disorientation, yeah, altered mental status in the hospital settings. Any doubt on the delirium?
No, thank you.
No, thank you.
So that was all on this page. Any doubt, please ask on this page. Now,
No,
No, thank you.
okay. Okay, then you have the psychosis. Okay, in the psychosis, you will have a delusions, hallucinations, disorganized speech or thought. What there are, let's discuss. So first are the delusions. Delusions are kind of a fixed false belief. No matter how many evidences you give against these delusions, the patient will still believe these delusions. Okay, like they will think that someone is planning their murder, or some kind of a factory is planning some kind of a toxin in their farm. And no matter how many evidences, you will install the cameras, you will do everything to prove that the patient is wrong, but they won't believe on that evidences. They still believe their fixed beliefs. Okay, they may accuse their partner of being unfaithful sometimes, and no matter how many evidences that partner give, they still don't believe that. Okay, so these are the fixed false beliefs. Okay, idiosyncratic beliefs that despite of evidences to the contrary and are not typical. Okay, the patient who believes that others are reading his thoughts, no matter how many evidences you give against that, the patient still believes that condition. Okay, there are of many types. Okay, you don't know to go you don't need to know the this every specific type. Just know they can be this erotomanic, it could be grandiose, it could be jealous, it could be persecutory, it could be somatic, mixed, or unspecified. Okay, second, you have the disorganized thought, in which the patient can have a word salad. He will just like a Wernicke's encephalopathy. Oh, sorry, not a Wernicke's. What was that area after the Broca's? I'm forgetting the name. Sorry, aphasia, comprehensiveness, Wernicke's areas, right? It was.
yeah, yeah.
Yeah.
Ah, okay. It's just like in case of a Wernicke's aphasia, you get similar symptoms. The patient will have a with this word salad, like they will say the cow said how he had to bow. So their sentence does not make any sense. It does not make any meaning, right? They're just saying whatever they want. They always changes their topic. They will switch into different topics. Okay, so that kind of a speech is present in the disorganized thought. Okay, so the changes of the subjects very frequently. They will have a clanging. Okay, they will make rhyme, but they don't make any sense. Like the cow said how he had to bow. This sentence is making the rhyme, but it do not make any sense at all. Thirdly, they will have the hallucinations. Okay, and the in hallucinations they have some kind of a imagination or some kind of a vision, and they believe on that vision. Unlike in my case of depersonalization derealization disorder, they will believe on these on these kind of a visuals, right? So so it is will be a perception of the ups it will be a perceptions in the absence of an external stimulus, like they see a light which is not actually present. They see someone some kind of a dead person which is who is not present there, right? So some kind of illusions are there, you can say. Okay, so these are the auditory. Okay, whenever patient start hearing some voices which are actually not present. Okay, it is generally seen in the schizophrenia, which will be discussed later. Second are the visual hallucinations, in which patient has a vision, some kind of a light, some kind of a dead person who is not there, and it's generally seen in the delirium patient and in the patients having a drug intoxication. So most commonly, whenever you see a delirium, yeah, it will always tell you about a visual hallucinations. They will be seeing some kind of a, they will be seeing some patients or some friends or some family members who are dead, who are not present there. They will be talking to someone, right? Then tactile hallucinations are present, and these are generally seen in the alcoholic withdrawal syndromes. Okay, the patient will say that someone is crawling on their chest, some kind of an insect is crawling on their chest, while in reality there was nothing. So these are the tactile hallucinations. Then you have the olfactory hallucinations, which is like a burning, a smell of a burning tire. It could be. So abnormal smell will be present. It generally seen in the uh, in case of a migraine, or in case of a seizures, you will see the olfactory hallucinations. Then you have our gustatory, and again, they will be seen in the epilepsy. You will have some kind of abdominal movements. Okay. Then you have the you will have this hypopompic, okay, hypnopompic and hypnagogic, and they are generally seen with the narcolepsy. You will have the hallucinations just before going to bed or just after wake up. Okay, so if it happens before going to the sleep, you will call it a hypnagogic. If it happens after waking up, you will call it a hypnopompic. Okay, and they are seen in the narcolepsy. We will discuss that later. So, any doubt on the delusions, disorganized thought, and the hallucinations?
No, thank you.
No, thank you.
So whenever you encounter a patient having all these three or any two of these three, you will call it a psychotic patient. And please know the difference between the depersonalization disorder and the psychosis. They will have a belief on whatever they are seeing, whatever they are believing. Okay, but in case of my depersonalization derealization disorder, you will the patient won't believe on their visual, right? That is important thing. Now you have the schizophrenia, okay, and other related disorders. Okay, so let's first discuss schizophrenia. To diagnose a patient with the schizophrenia, okay, you have two type of symptoms. One are the positive symptoms and one are the negative symptoms. The positive symptoms include hallucinations, delusions, and the disorganized speech. We have discussed that already. Okay, and the bizarre behavior is also there. For the negative symptoms, the patient will have a flat or the blunted affect. Okay, they will have a decreased emotions, decreased interest in anything. Okay, they will have a social withdrawal. Okay, they will have allergia. Okay, that means a poverty with their speech. They will only answer you with yes or no whenever you ask them something. They will have a decreased motivation, decreased goals. So everything negative about the patient. So in the positive symptoms, you're having some kind of a hyperactivity. In case of negative symptoms, you're having a hypoactivity. Okay, they will also, whenever they have an acute attack of the psychosis, of the schizophrenia, they will always loses their cognitive ability. They cannot make plans. Okay, they cannot understand anything. Okay, so whenever you encounter a patient having an acute psychosis or an acute schizophrenia attack, they will loses their cognitive ability also. In order to diagnose the schizophrenia, the patient must be having more than two of the following symptoms, and more than one symptoms must be from the positive ones. Okay, that means the delusions, hallucinations, and the disorganized speech. At least one of these three symptoms must be present. And other than that, patient can have the negative symptoms also. Okay, like the all these flat effects or the allergia or the social withdrawal. Okay, so whenever you encounter a patient having any of these three symptom, okay, as well as a negative symptom, think about the schizophrenia, and the symptoms must be present for more than 6 months. If you encounter a patient having the symptoms for less than 1 month, you will call it a brief psychotic disorder. Okay, all that criteria with less than 1 month, you will call it a brief psychotic disorder. If the symptoms are present for less than 6 months, more than 1 month, you will call it a schizophreniform disorder. Okay, and after 6 months, you will call it a schizophrenia. Okay, any doubts so far?
No, thank you.
Now, Stephen will ask you why the symptoms are positive and negative are happening in case of my schizophrenia. So you must know the dopamine pathways for that, right? I told you about the mesolimbic pathway and the mesocortical pathway. For a decrease, due to a decrease in the dopamine in the mesocortical pathway, you are having a negative symptoms, and due to a decrease and due to an increase in the dopamine in the mesolimbic pathway, you are having a positive symptom. Okay.
Yeah.
And the negative symptoms are because of a high serotonin activity. Okay, in the mesocortical pathway, because of a high serotonin in the mesocortical pathway, it will decreases the release of dopamine, and that causes the negative symptoms. Okay, and that's exactly what your atypical antipsychotics inhibit. Okay, the serotonin neurotransmitters. You will have a ventriculomegaly on the brain imagings. Okay, and it will increases the suicidal risk of the patient. Okay, heavy cannabis use can cause the schizophrenia. And please note, you will have a lateral ventricles enlargement in case of the schizophrenia. So heavy cannabis, lateral ventricles, decreased dendritic branching. These three findings you will see on the MRI of the patient. The treatment includes the atypical antipsychotics, and these are the first line therapy. Okay, and please note, that the schizophrenia can be associated with the Alzheimer's also, with all these dementia disorders. You can have the psychosis also, and you, in that case, you won't call it a psychosis, but you will diagnose them with the dementia disorders like the Alzheimer's, for example. In case of Alzheimer's, patient will have a loss of memory. Okay, they will have the loss of all this cognitive ability, along with sometimes a psychotic episodes. And in that case, you won't call it a schizophrenia, but you call it a Alzheimer's, right? And that is an important thing. Any doubt on the schizophrenia, how you diagnose it?
No.
Now, then after schizophrenia, you can also have the postpartum psychosis. Okay, it would be a woman who has a history of the psychotic disorder. Okay, and they're on some kind of a treatment for the psychosis, but due to the pregnancy, they stop taking that drug. After the delivery, the patient can again have the psychosis. They will have the delusions and the hallucinations which are associated with the death of their baby. Okay, it always involves the baby, right? So basically the baby is at a risk of getting murdered by the parents themselves, right? In that case, you have to take away the baby. Okay, and that is the postpartum psychosis. Okay, all the psychosis and delusions, they are often involving the baby, like a sound who is telling the mother to kill the baby, right? So that's why there's a life-threatening condition for the baby. You need to keep the parents away from the baby, and that is the postpartum psychosis. Any doubt?
No, thank you.
Now, again, you have the schizoaffective disorder. Okay, in this condition, both the mood disorders and the schizophrenia is present. Okay, but you have the schizophrenia without the mood disorders. The mood disorders could be a maniac, could be a depression. That means a hyperactivity could be there, hypoactivity could be there, along with the psychosis. Whenever you get that, okay, you have two things. One is the schizoaffective, okay, and second is the bipolar disorder, or you can say MDD with psychotic features. In order to differentiate it with other conditions, you need to make sure that the psychosis is present without a history of mood disorder. That means, let's say, if this is my patient, and at that point he started having the psychosis, okay, he's having the psychosis for like 6 months, you call it as schizophrenia. In between this 6 months period, at some point of time, they have the mood symptoms. Okay, then a time which is without the mood symptoms, and this time must be more than 2 weeks. More than 2 weeks, they must be having a schizophrenia without any mood disorder. Then they again get some kind of a mood disorder in between the psychotic episodes. Okay, so a patient who is having a mood disorder in between the psychotic episodes, you call it a schizoaffective disorder. Okay, so delusions, hallucinations that last more than 2 weeks beyond a mood disorder, you call it a schizoaffective. Any doubt?
No, thank you.
While in case of my MDD with psychotic feature, you will see a patient who is having a depression. Okay, and this is a time period for a depression. In between my depression episodes, the patient will have some episodes of the psychosis. So in this scenario, psychosis is existing only with the depression, while you can have depression without psychosis. But in case of my schizoaffective disorder, the depression, or this maniac episode is associated with my psychosis. It cannot exist without the psychosis, but the psychosis is existing without any mood disorder, right?
Yeah.
That is a huge difference between the schizoaffective disorder or the MDD with psychotic features. Okay. Then you have a schizotypal personality disorder, which is a clustered A-type personality disorder, in which again the patient will have some kind of a fixed beliefs, they will have some delusions, some psychotic features, but they cannot meet the diagnosis of the schizophrenia. Okay, They cannot meet a diagnosis of the schizophrenia. If they are meeting the diagnosis of the schizophrenia, you call it a schizophrenia, not a schizotypal personality disorder. So it is kind of a less severe condition than the schizophrenia, you can say. And please note, it happens only in the patient more than 18 years, because up to the 18 years, the patient is still developing their personality, right? So the schizotypal personality disorder can only exist after 18 years of age. Any doubt on the schizophrenia and associated disorders?
No, thank you.
No. Thank you.
Then you have the mood disorder. Okay. And in the mood disorder, you can have the maniac episode, okay, which is a one extreme thing. And second, you can have the depression episode, which is again one extreme thing. Okay. We all are exist in between these type of, for example, you either can have a super elevated mood, an extreme condition, which is known as the maniac, or you can have a super depressive mode. You call it a depression. While we all are normal person exist in between these two, okay, if the patient is starting having the extreme of these, you call it a mood disorder. Okay. And the mood disorders includes all the major depression, the bipolar disorder, dysthymic disorder, and cyclothymic disorder. We will discuss all of these one by one later. Sometimes all these mood disorders can be associated with the psychosis also, and you will have a different diagnosis with them. Either it could be a mood disorder with psychosis or a schizoaffective disorder also. So let's discuss what the maniac is, what a maniac episode is look like. It would be a patient who become very aggressive, very irritable. Okay, symptoms should be more than 3 of any of these, and they must be lasting for more than 1 week. Okay, so any of the 3 symptoms among them must be lasting for more than 1 week, and patient must be having a irritable or a aggressive mood. You call it a maniac episode. Now you must remember the mnemonic that dig fast. D means the distractibility. They will have a very decreased focus. They will become easily distractible. They will have the impulsivity, which means a risk-taking behavior. They cannot, they do not think about the consequences of what they're doing. They just want to do. They're just doing whatever they want to do. If they're traveling, they want to travel everywhere without thinking about the expenses. If they're gambling, they will gamble without thinking about the loss of their money or anything. So basically, they have a risk-taking behavior. If they're involved in the sexual activities, then they just have the these activities without thinking of any of the infections, right? So they will have a impulsivity. They will seek pleasures without thinking about the consequences. They will have a grandiosity. They will have an inflated self-esteem. They think that they are somewhat special than others. They have a special purpose on this world. Okay, like they're a part of God, or they're a mission from the God, something like that. So they will have a grandiosity. Okay, our self-esteem is increased. Then you have the flight of ideas, the mnemonic F. Okay, they will have a racing thoughts. They will switch on topics. Okay, they will become very much agitative. Okay, they will have the agitation and they will become very much aggressive. Hyperactivity will be there. Okay, they cannot sleep for more than 1 week. It would be a patient who is only sleeping for like 1 or 2 hours every day. Okay, and then they're playing guitars for like 1 week continuously. They cannot sleep for 1 week continuously. They're doing any activity, any their hobby, like they're painting for 1 week without sleeping, right? They're playing music. Okay, they're playing guitar without sleeping for like 1 week. So think about that. Increase activity and decrease need of sleep. They will have a very high talkativeness and the pressured speech. Okay, they will talk constantly with a rapid fire pace. They will interrupt others while they are talking. Okay, so these are all the symptoms which are present in the maniac episode. Please note, you will have 7 symptoms that dig fast. Okay, you need at least 3 symptoms for more than 1 week, and 1 symptom must be a decrease in the sleep, and that is a must thing. Patients should not be able to sleep for more than 1 week. Okay, and they must have the aggressiveness also. They can beat their partner, they can and they can assault their partners. Okay, they will verbally abuse their partners, right? That kind of symptoms will be present in the maniac episode. Any doubt?
No, thank you.
We did discuss delusional disorder.
We can discuss the.
We didn't discuss the delusional disorders.
Sorry, I couldn't hear. Repeat it
Delusional,
again, please.
delusional disorder, just below schizoaffective disorder.
Oh, yeah, this one. Yeah, we forget, right? In the delusion disorder, you just have the delusion without any psychosis. Okay. If you just have the delusion, that means a fixed false belief, okay, without any hallucination, without any disorganized speech, without any functional decline. That is a must thing. You must not have any kind of functional decline. The patient, if he's a driver, for say, then he must be doing his job normally. Okay, but whenever he come back home, they have this fixed belief. They're thinking about their delusions all the time, but it do not affect their working life or or their personal life at all. And that is known as the delusion disorder. If they think that I got a question from the UWorld, I think, and it was a patient who is believing that a nearby chemical factory is mixing some kind of a chemical in their farm, and he was a taxi driver. He's doing his job properly. He's not having any problem with their job, but they have this fixed belief even after installing the cameras, or even after telling him many times that they are not doing anything in their farm. He's still believing that false belief. Okay, he's still believing on them that they're doing the illegal activities in their farm. So a patient who is having a fixed belief, and no matter how many evidences you give to them, they still believe on that particular thing, right? That is the delusional disorder. And sometimes the delusion becomes so much severe than even the partner start believing on their delusions. Okay, and that is one of the folia adiox. Okay, when in the relationship, even the partner still start believing on their delusions. Okay, sometimes they become that much severe. Okay,
Yeah.
so they must have no hallucinations, no history of mania, no history of depression, nothing, just a fixed delusion for more than 1 month. Okay,
Yeah. Thank you.
that was about it. So we have discussed the maniac, and now let's discuss the hypomaniac. Whenever you cannot diagnose a patient with the maniac, because for the maniac you need more than 3 symptoms for more than 1 week, right? And a symptom must be a decrease in the sleep, aggressiveness, and other than that, 2 more symptoms out of these, right? Whenever you cannot diagnose a patient fully with the maniac, you call it a hypomaniac patient. So a hypomaniac patient must not meet the full criteria of maniac. First thing is there. Okay, it is kind of a similar to my maniac episode, but like in case of my maniac, I'm having a functional decline. I'm starting having some activities which I shouldn't be doing, like playing the guitar all day and night without sleeping. Okay, so they are not benefiting the patient at all. But a hypomaniac patient actually benefiting the patient. They will have this increased activity, and and they have a decreased sleep. In that duration, okay, they will finish their pending work. Okay, they will work on their hobbies. Okay, they will diagnose something, or they will they discover something like that. Okay, so basically the hypomaniac episode is kind of a very much beneficial to the patient, you can say. Okay, it leads to a predictive it leads to a productive outcome of the patient. Okay, so it will be a patient having a very high activity for more than 4 weeks, not a week, 4 days, not a week. Okay, and the patient must be having less than 3 symptoms of the all these dig fast that we have discussed. Out of 7, the patient will be having a less than 3 symptoms, not a particular 3. Okay, you call it a hypomania. Okay,
Yeah.
any doubt between the differentiation between the maniac and the hypomaniac episode?
No, thank you.
Okay, so it will be a mood disturbance which is not severe enough to cause the mark impairment or a functional decline. It even helped the patient on their work. Okay, now you have the bipolar disorder. Okay, in case of my bipolar disorder, the patient is switching between the hyperactivity and the hypoactivity. That means between the maniac and between the depression. At one time, they have this hyperactivity, that means a maniac episode. And then after 1 or 2 months later, they started having the depression. Then again, after 1 or 2 months later, they're having the depression, and then the maniac, and then again depression. So whenever you encounter such kind of a patient, you call it a bipolar disorder. So for a bipolar disorder, the patient must be having more than one maniac episode with or without a hypomaniac episode plus a depressive episode. You call it a bipolar. Please note that the maniac disorder, you cannot diagnose it individually or independently. Whenever you got a patient with a maniac episode, having a maniac episode, you always call them the bipolar one. That is the important thing. Okay, even if you do not have any history of depression, just a history of the maniac episode, you still call them the bipolar one if they have the maniac. If you encounter a patient who is having a hypomaniac episode, okay, that means they're doing their homework properly without sleeping day and night, okay, and but they do not have any functional decline, and they do not have any need to hospitalized, okay, because a maniac patient must be hospitalized, but a hypomaniac patient, they do not got any need to hospitalize the patient, right? So whenever you encounter a patient with the hypomaniac episode or having a depression, both things must be there, a hypomaniac episode and a depression, but not the maniac. You call it a bipolar 2 disorder. Okay. And patient mostly they do not have any history of hospitalization because the hospitalization is only present in case of the maniac episode. Okay, you won't admit a hypomaniac patient because actually they're beneficial for them. Okay. So in that case, the treatment of choice is the lithium. Okay, it actually depends on what symptoms the patient is happening. Okay, is getting. So you have three things. If the patient is having a bipolar disorder, which is maniac predominant, you will give the patient lithium. If the patient is having a bipolar disorder, which is depression predominant, you give them the lamotrigine. If they're having a patient, if you're having a patient who is kind of fluctuating between the depression and mania, the depression and mania again, you will give them the valproate or the carbamazepine. Both will be useful. Okay, so depending upon the type of symptoms patient is having, if you encounter the patient having a having a maniac episode, at the time you diagnose them, you will give them the lithium. If you diagnose the patient having a depression and with the bipolar disorder, you will give them the lamotrigine. If the patient is kind of fluctuating between these two, you will give them the valproate or the carbamazepine. Any doubt on the treatment?
No, thank you.
No, thank you.
Any doubt on differentiating between the bipolar 1 and bipolar 2?
No, thank you.
So in the treatment, you would be giving lithium or lamotrigine, depending on whichever, if he has more manic or more mellow symptoms.
Yes, it depends, exactly.
Okay, thank you.
Okay, whenever a patient got a acute maniac episode, okay, you can also use the benzodiazepines in them. But please note, the benzodiazepines cannot be used as a chronic therapy. They must be used only for the acute therapy because all of these drugs will take time to get the action, right? So benzodiazepines will be a useful one also. Then comes the cyclothymic disorder. In that case, the patient can never be fully diagnosed with the maniac or with the depression. In order to diagnose a patient with the maniac, you need at least 3 out of 7 symptoms. So it would be a patient having 1 or 2 symptoms of the maniac, not the 3. Okay, for diagnosis of the MDD, you need at least 5 symptoms out of the 9. Okay. So it would be a patient having less than 5 symptoms of the depression, less than 3 symptoms of the maniac. So these patients can never be fully diagnosed with the depression or can never be fully diagnosed with the maniac. And the symptoms must be present for more than 2 years duration. Okay, the patient will have a period of a normal time where they do not have any of the symptom, either the depression or the maniac. But this remission should not last for more than 2 months. So it would be a patient, if this is a 2-year timeline of a patient, okay, so they must be having an episode here which is not fully depression or not fully maniac. Then they will have a relaxation from all these episodes, a normal time which is less than 2 months. Okay. Then again having the episodes of either the depression or either the maniac, not fully diagnosed with them. Okay. Then again a normal episode which is lasting less than 2 months. Then again similar kind of episodes. Then again normal period. Again some kind of episode. Right. This kind of a patient, you will diagnose them with the cyclothymic disorder. If you diagnosed them either with the depression fully or either with the maniac, then you cannot diagnose them with the cyclothymia, because a patient of bipolar disorder can have a very prolonged history of like 5 years or 6 years. For example, they have this maniac episode at one time, and after 4 or 5 years later they're having a depression episode. Then again after 2 or 3 years later they're having again the maniac episode. You cannot call them the cyclothymic. Okay, because for a cyclothymic, the patient must be having a numerous episodes, and the time gap between the two episodes must be less than 2 months. Okay, are they good?
Yes.
So tell me, can this cyclothymic disorder patient have any history of hospitalization?
No.
No,
No.
because you will only hospitalize a maniac patient or a depressive
Maniac.
patient, right? But they're not
Yes.
having either a fully depression or either a fully maniac. So, they generally do not have any history of hospitalization before. Okay, that is an important thing to take. Similarly, for my bipolar disorder 2, the patients can be admitted for the depression, but they never can be admitted for the maniac. But in case of my bipolar 1, they must have a history of hospitalization with the maniac episode. Okay, it could be a patient who is now having a depression, and when you ask them about any of the mood symptom previously, they will tell you that once, like 2 or 3 years before, they were hospitalized for having a maniac episode. So they have a history of hospitalization. Okay, so whenever you encounter a patient with a depression, please note you always had to take their history for a mood disorder, for a mood symptom, for a maniac symptom. Because if you give the patient any antidepressive therapy, whenever you encounter a patient with a depression, if without taking their previous history of hospitalization, if you just give them any SSRI or the SNRI, it can it can precipitate the mood symptoms of the patient, and they can have the maniac symptom then, the maniac episode then. Okay, so always you need to take the history of the maniac episode before diagnosing a patient with the MDD. Okay, that is a most important thing. Okay.
Yes.
Yes.
Because antidepressants increases the risk of mania. So before prescribing the antidepressant, a history of maniac episode should be taken first. Step 1 can ask you this thing. Okay, they will give you a patient who is having a depression. He's admitted to the hospital. He's given the SSRIs, and only after 2 or 3 days later, the patient stopped taking the drug. Okay, they will tell you that they're having this high mood. Okay, they have this increased energy. They cannot sleep for weeks. They're feeling very confident, right? Only after 3 to 4 days of the drug. So that's how you know that the patient is having a previous attack of the maniac, which you forget to diagnose first. Okay, so that kind of a thing will be there. Then you have the major depressive disorder. For the diagnosis, you must have the symptoms lasting more than 2 weeks, and at least 5 of the 9 symptoms must be present. And the symptoms are the Diggs space. The D means a depression, which is must there. This is a must symptom. Second is the decrease in the interest. Okay. Third is the guilt. Okay, or the feeling of worthlessness. Okay. Fourth is basically a sleep disturbance. It could be a hypersomnia. It could be an insomnia. Okay. They will have the history of a suicidal ideation. Okay. They will tell you that they once tried to commit a suicide. Okay. They will have a history of psychomotor retardation or agitation. Okay. They will have an increase or decrease in the appetite. That means they can either have a weight gain or a weight loss after the depression. Okay. They will have a decrease in the concentration, easily distractible they will be, and a decrease in the energy to do anything will be there. So these are the 9 symptoms, and whenever you encounter a patient having at least 5 of the 9 symptoms for more than 2 weeks, you will call them a depression. Doesn't matter whatever associations are there, you will always diagnose them with the depression whenever you have this kind of a full diagnosis criteria. Okay. Before prescribing any drug, you need to always take the history for the maniac or the hypomaniac episode to rule out the bipolar disorder, because the antidepressants can trigger the mania. Treatment include the SSRIs, SNRIs, metrazepam, bupropion, electroconvulsive therapies. Okay, and all of them we will discuss later. And they will ask you about the sleep pattern of a depressive patient. And please note they will have an increased frequency of the REM sleep and the increased duration of the a decrease in the latency of the REM. So increased frequency, that means a decreased latency, of course, and an increased duration. So a total REM time will be increased in the MDD patient. Okay. Depression is very common in the old age. Okay. So whenever you encounter a patient who is of a very old age, and they're showing one or two symptoms of the depression, then you first need to identify any other symptom of the depression to diagnose them for the depression first. Okay. Whenever a patient having any illness or having a recent separation or any kind of a psychological trauma, okay, they can get the depression. So whenever you encounter a patient who is having a cancer history, okay, or having a social withdrawal, okay, and they tell you that and they're having a loss of interest, okay, or they're having a very high sleep, okay, so you must think that the patient can be having a depression. So you must need to test them for the depression first. That is the important thing. Okay. And depression can be exist with the dementia also, very important. Okay. And you call it the dementia with the depression, right? So depression in the late life, it can be related with the cognitive impairment also. Okay. Symptoms are always acute in the onset. Okay. And yeah, the dementia with the symptoms of the MDD. Okay. So that could be also be present. Okay. Depression in the late life, you will call it. Any doubt?
No, thank you.
Please note, whenever you encounter the old age patients are having a very high risk of developing the depression. Okay, most of the patients who got diagnosed with the depression, they are of old age. So any old age patient having one or two symptoms of the depression, you must test them fully with the diagnosis of the depression first. Okay, now you have the MDD with the psychotic features, and we have discussed that already. You will have a depression, and in between the depression, along with the depression, sometimes you can have the psychosis also. That means hallucinations or the delusions or the disorganized speech. So whenever you encounter a patient who is having a delusion, hallucination, who is having a depression, and along with the depression, sometimes they have the psychotic episodes. You will think about the MDD with psychotic features. Please note that depression must be existing without the psychosis. But in case of your schizoaffective disorder, the psychosis must be existing without a mood disorder, without a mood symptom. Okay.
Yes.
So that was about the MDD with psychotic features. Then you have the persistent depressive disorder or the dysthymia. Please note, in this disorder, symptoms of the depression must be present for more than 2 years. Okay, and the patient must not be fully diagnosed with the depression. Even if they're having only 2 or 3 symptoms of the depression for more than 2 years, you will call it a persistent depressive disorder or the dysthymia, similar to that of cyclothymia, right? Symptoms for more than 2 years with a remission lasting less than 2 months. Similar diagnosis criteria exist in the dysthymia disorder also. Okay.
Yeah.
Other type of depression is the MDD with seasonal patterns. With the seasons, the patient can have a depression. They can have a depression in the summers, or they can have a depression in the winters. But then in the in the other season, the patient will become absolutely normal. So this is the MDD with seasonal patterns. Very easy to diagnose. It should be present in more than 2 years. Okay, and that was about it. Then you have a depression with the atypical feature, and that is the important one. Okay, the atypical features along with the depression, of course, they are the mood reactivity. Okay, whenever something good happened to them, to the patient, they will feel they will feel very elevated, they will feel very happy, and then again after some time they feel again the depression, and then again whenever something happened with them, something good happened with them, they again feel very good, and then after hours or days later they again having the depression. This is the mood reactivity, a transient improvement in the response of a patient, a positive response you get. Second is the hypersomnia, third is the hyperphagia, and fourth is the laden paralysis. You will feel a very heaviness in the arms. Patient will feel the heaviness in the arms, and that is known as the laden paralysis. So MDD along with any of these 4 features, you will diagnose the patient with the depression with atypical features. Okay.
Yes.
So step 1 can ask you, okay, about this thing, that in order to diagnose a patient with the depression with atypical features, what other symptoms must be present? Or please note that for the treatment of the depression with atypical features, you must use the SSRIs or the MAO inhibitors. Okay, you can sometimes even avoid the SSRIs and directly can start the MAO. And the step 1 can ask you this fact, that in a patient who is started on the MAO therapies, okay, what symptoms other than the depression must be present? Okay, so that the so that the physician started the MAO therapy instead of the SSRIs first. So it would be either the mood reactivity or the hypersomnia or the hyperphagia or the latent paralysis. So that kind of a questions can be framed on the depression with atypical features. Okay.
Yeah.
So that was it. Okay. So any doubt on the depression or on the, any of the mood disorder or any psychosis?
No, thank you.
No, thank you.
Just like in the childhood, you're having a disruptive mood dysregulation disorder in which you got this anger outburst suddenly, right? Even in a normal situation, you in the adulthood, you also have the intermittent explosive disorder. Okay, you will have a sudden anger outburst, short-tempered patient it would be. Okay, they can even become verbally or even physically abusive to their partner. Okay, they will have the domestic violence history. Okay, so tell me, how would you differentiate between the intermittent explosive disorder and the conduct disorder? Because in both the cases, you're having a very high aggression.
No damage to properties or any harm to other people.
Well, in case of my intermittent explosive disorder, the patient will be harming their partners, domestic violence.
Age?
In both the conditions, you can have in the antisocial personality disorder, it would be more than 18 plus, and so does the intermittent explosive disorder. Both are 18 plus.
Probably in intermittent explosive disorder, there will be no previous history of any kind of such actions of the patient. But in
Like what actions?
like the person did not used to get angry before the age of 18 or something.
No, they kind of have this history before. Like a history of the disruptive mood dysregulation disorder could be present in the intermittent explosive disorder. So they can have a history of aggressiveness before also in the school time. The important thing is the remorse. In case of a conduct disorder or the antisocial personality disorder, the patient do not have any remorse for the other. They don't feel any pity about others. Okay, they instead make fun of them, or they tell you that, you know, whatever happened to that person, they actually deserved it, right? They don't have any kind of remorse. In case of my intermittent explosive disorder, the patient will have the remorse after that anger outburst. When they become verbally or physically abusive with their partners, they will have this remorse about them. They will feel very guilty that whatever they did was wrong. They shouldn't be doing that, right? So this remorse will differentiate it with the conduct or the antisocial personality disorder. Okay.
Yes.
So that was on this page. Then you have the postpartum mood disturbances. Okay, and all of these conditions happen after the pregnancy. It all depends upon the timeline of the patient. Okay, first you have the postpartum blues. Okay, and it will be just a feeling of sadness. Okay, that happens shortly after the birth of the baby. Okay, the patient will have a depressive kind of effect. They will have a sadness. They will become very tearful. They often cry. Okay, they have this fatigue, and it happened and it started happening 2 to 3 days after the delivery. Okay, and it must resolve within 2 weeks. So all this sadness, all this crying, all this fatigue, it must be resolved within the 2 weeks. If it persisted after the 2 weeks, and that's exactly what you need for the diagnosis of the MDD, right? You need the symptoms to be lasting for more than 2 weeks.
Yes.
Right? So after 2 weeks, you will diagnose it with the MDD. Okay. And please note, you won't call it a MDD with postpartum onset, with peripartum onset if it happens after 1 year of the delivery. Okay, it should be present within 1 year of the delivery of the baby. Okay, and these are generally a patient who are having a very previous history of MDD, and because of the pregnancy, they stopped taking these drug therapies, and now they're again after the pregnancy, they started having these all episodes of the depression. So they can have a history of depression before, even before the birth, right? Now comes the postpartum psychosis. Okay. And for that, the patient will have a delusions, hallucinations, and thoughts like we have discussed previously. They will have all these delusions, hallucinations, and thoughts of killing the baby. These thoughts will always involve the baby, like some kind of a voice or some kind of thing is telling them to kill their baby, right? So it will be a very threat to the baby. So you must take the baby away from the patient. Okay, in case of a postpartum psychosis. Generally, the patients who get this postpartum psychosis, they have a previous history of the psychosis for which they were taking the medicines, but they stopped due to the pregnancy. Okay, risk factors include the first pregnancy, family history, bipolar disorder, any other psychotic disorders, or a recent medication change. Treatment should be the hospitalization and initiation of the atypical antipsychotics. Okay, and baby must be kept away from the patient also, right? All these thoughts are involved the harming of the baby or the self. Because any doubt?
No, thank you.
So please note, before 2 weeks, it is just a postpartum blues. And what you will tell the patient whenever they tell you that they're having the depression, tearing, and all this fatigue soon after the birth, before 2 weeks, what would you tell them? Or what would you do? You will prescribe a drug or something?
No drug.
No drug. Whenever you encounter a patient who is having this kind of a depression effect before 2 weeks, soon after the birth, you will tell them to wait for 2 weeks. Okay, you will tell them to monitor themselves for at least 2 weeks. Only after 2 weeks, if they have the persistent symptoms, you will give them the drug therapy. But before that, you just have to wait, because the symptoms are generally limited, self-limited. Okay, after 2 weeks, they will be resolved. Okay.
Yes.
That was about it. Then you have the grief. Okay, you need to know about the 5 stages. Okay, the first one is the denial, and that we have discussed, which is a ego defense, right? Whenever some person dies of a relative of the patient, and a relative dies, they first are in a denial phase. They do not just believe that the person is gone. Okay, so they will be in a denial phase. Then they will become very much angry, okay, of the physician, maybe that you could not save them or something like that. Then they start bargaining that take my life instead of them. Okay, then they get a depression sometimes. Okay, and finally they will get the acceptance. They will accept the death of their relative or the loved ones. Okay, so first is a denial, then the anger, bargaining, depression, and the acceptance. All these symptoms must be resolved within a 12-month period. If the symptoms of the grief persisted after 12 months, you will call it a MDD, major depressive disorder. Okay, or a grief, atypical type of grief, you will call it. Okay, generally a patient will get the depression. Okay, and they will also get the hallucinations sometimes. Okay, they will see their loved ones. Okay, they will have the suicidal thoughts, but all the suicidal thoughts are only to join their loved ones in the death. Okay, not because of any other condition, not because of any other issue. Okay, just because they want to join their loved ones, they will have the suicidal ideation sometimes, and it is all normal up to the 12 months. Okay, they can hear voices of their loved ones, they can see their loved ones standing in front of them. That means all the psychotic episodes they can get, but only within the 12-month periods. All the psychosis, all the suicidal ideation, all the depressions are only all these things are all these things revolve only around these loved ones, right? They will have all these thoughts of their loved ones only. If they have any other thought other than their loved ones, it will be a atypical type of grief. Okay, or a complete psychosis it could be. Okay, They do not, and the very most important thing, that they do not have any functional decline in grief. A functional decline, you say, whenever a patient stop doing activities which they used to do before the episode. Okay, like going to a church or cycling or cooking or interaction with the, with the other persons. So if they stop doing such activities, okay, you will call it a atypical type of grief. If they have the functional decline, that means a decrease in socialization or decrease going to the church. So basically they are doing activities which the person, they are not doing activities which they were used to do before, and you will call it a pathological grief in that case. If after 12 months all these symptoms persist, you will again call it a pathological grief. If the patient can be diagnosed with the full depression, that means all the 5 symptoms of the depression for more than 2 weeks, you cannot call it a grief. Even before even before a 12-month period, you will call it a depression again. Okay, so a patient who is having this kind of a trauma, a loss of loved ones, okay, and if you're fully diagnosing them with the depression, then you must go for the diagnosis of depression, not with the grief. Okay.
Yes.
And please note, in a child who is less than 6 years old, okay, they cannot understand the death now. Okay, only after 6 years old, they started to know that the death is kind of irreversible thing, right? So for a child, displaying abnormal behavior is totally normal. And you need to know that if you encounter a child who is having a age less than 6 years, and in the vignette they're telling you that all these symptoms are kind of very much abnormal, okay, but you please need to know that up to the 6 years old child, it is totally normal. Only after 6 years old you will call it a abnormal or a pathological grief. Before 6 year, before 6 year for a child, it will always be a normal behavior answer. Okay.
Yes.
So any doubt on the grief or pathological grief or MDD?
No, thank you.
No, thank you.
So that was about the grief. Then you have the electroconvulsive therapies, and you use them for the psychotic symptoms, mainly for the depression. Okay. And if the patient is having an acute suicidality, then you must give them the electroconvulsive therapy. Electroconvulsive therapy is also very much safe in the pregnancy. So in the pregnancy, you mainly do the electroconvulsive therapy other than the drugs. Okay. In that case, you will give a patient a kind of a shock in the brain, and that shock induces the tonic-clonic seizures under the anesthesia. And because they're under the anesthesia, patient do not have any kind of a movement. They will have the neuronal firings, but they do not have any kind of a movement. Okay, so a neuromuscular blockade will be given. Okay, anesthesia will be given, and then you will induce the tonic-clonic seizures. And after this therapy, patient will feel very light, very happy. Okay, all the symptoms will be gone. So this is the electroconvulsive therapy. Okay, any doubt?
No, thank you.
Then you have the risk factors for the suicide completion. Okay, the most important one you must remember is a history of a previous attempt. That is the most important one. If a patient is having a history of a previous suicide attempt, then a very high chances are there that this time patient will have a complete suicide. Okay, and that is the most important. It will overcome any of other these risk factors. Okay, other factors include the male. Male will have a very high chance of completing the suicide than the females. Females can have a more frequency of suicide, but they are mostly incomplete type of suicides. While male, they have a less attempts of suicide, but often they have a complete suicide. Okay, then the age is very important. Okay, it would be either an adult or an elderly. History of depression is very important. If they have a history of depression, it will make a very good candidate for the complete suicide. Any drug abuse can do that. Psychosis, having if the psychosis involve killing themselves, then they will kill themselves, believing this psychosis. Sickness can do that. Whenever I told you a patient who is elderly having any kind of a sickness, okay, they will become very much prone developing the depression, and then they will get the suicide also. An organized plan, okay, like having a gun or like having a fan with a rope tied on it. Okay, so having an organized plan will make them a complete suicide patient. Okay, and having a no spouse or any kind of a social support, like any friends or relative. If the patient is kind of a socially isolated, okay, it will make them very prone getting a suicide. Okay, very important. Now, please note that the most common method of suicide in the United States is the firearms. Okay, so whenever you encounter a patient who is telling you that they have a firearm in their home, you must advise them to lock the firearm. Okay, but the most important risk factor for getting a suicide is the previous attempt. Step one can ask you these facts. They will tell you that the patient is having, you know, having a history of suicide attempt, this suicide attempt. So we'll ask you what make them a very good candidate to develop, to get a complete suicide this time. They will tell you the options like the sex, age, previous history, family history, having a firearm or something like that. Please note that the most important thing is the previous attempt in them. Okay, women will try more often, but the men get a more complete suicide often. Okay. Other risk factors include the recent psychiatric hospitalizations or any family history. Any doubt?
No, thank you.
No.
So we will take a short break and then start the anxiety disorders.
Yes.
Okay.
Thank you.
Okay. Okay, so we are done up to the postpartum disturbances, grief, all these risk factors for the suicide. And now we are about to discuss the anxiety disorders. Now, before the anxiety disorders, let's discuss the trauma and the stress-related disorders first. Okay. So the first one is the adjustment disorder. Okay, with a sudden change in the environment of a patient, like traveling from one state to another or one place to another, or getting an emotional trauma, okay, or something like that, anything after a psychological stressor, that means a divorce, any illness, or after shifting to a new place. Okay, if the patient is starting having the symptoms of the anxiety, okay, or the outburst, any kind of, okay, and the symptoms must be occurring within the 3 months of this stressor. That means after shifting to a new place, or after divorce, or after getting an illness. Okay, if you're starting having the anxiety episodes within the 3 months that are lasting less than 6 months, okay, you will call it a adjustment disorders. If the symptoms are lasting for more than 6 months, you will call it a generalized anxiety disorder. So anxiety for more than 6 months, known as the generalized anxiety disorder. Having an anxiety less than 6 months, starting within the 3 months of the stressor, you call it a adjustment disorder. So for a diagnosis of my adjustment disorder, okay, uh, 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 stressor must be there, some kind of. For a diagnosis of generalized anxiety disorder, stressor is not required. It could be there, it could not be there. Okay, and symptoms must not meet the criteria for the MDD. Patient can have the depression also in place of anxiety. Okay, and the symptoms must not meet the criteria for the MDD to get a diagnosis of the adjustment disorder. It would be a patient having a psychological stressor, just like I told you, either moving to a new place or having a divorce or having an illness, and now the patient started having these all the symptoms of the depression. Okay, you call it a adjustment disorder. Treatment, again the CBT. For the depressions, you can give the patient antidepressants. For the anxiety, anxiolytics can also be given. Okay, then you have the post-traumatic stress disorder, the PTSD. Okay, after having a psychological stressor, and in that case it must be a life-threatening condition or a near life death experience. Okay, losing a loved one or seeing a death with the own eyes. Okay, a kind of sexual abuse or a rape, a serious injury, witnessing a death. Okay, so having a life-threatening situation after, okay, patient is starting having the hyper arousal. They become very hyper vigilant. It could be it could be a soldier, okay, returning after their trip to to other places, or having a after returning from a war or something like that. So they will become very hyper vigilant. Okay, hyper arousal would be there. They will avoid all the stimulus which can refresh their memories. Okay, they will always have the nightmares or the flashbacks for their for that event. Okay, it could be a patient working as a working in a fire extinguisher department, and he sees someone burning to the death. Okay, so they will have a nightmares or the flashbacks of their death. Okay, they will become very horror, it will cause them a functional decline. They will become very distressed. The disturbance must be lasting for more than 1 month. So a patient having a near-death experience, and now they started having all these nightmares and the flashbacks, okay, of that episode. Okay, they will become very hyper vigilant, alert. Okay, they will always avoid that stimulus. They can also have this dissociative disorder associated with the PTSD, and you call it a PTSD, not a dissociative disorder. Okay, they can have the personality split. They can have the loss of memory. Okay, they will become detached from their body, something like that. Treatment include the SSRIs. Venlafaxine are the first line. Prazosin, which you guys remember, what does this drug do?
Alpha 1 blocker.
Alpha 1 blocker, right? Prazosin can be used. Okay, and prazosin reduces the nightmares. Okay, now you call it a acute stress disorder if the symptoms are lasting for less than 1 month. If the symptoms are lasting for more than 1 month, you call it a PTSD. If the symptoms are lasting for less than 1 month, you call it a acute stress disorder. All the symptoms are present but less than 1 month, and the pharmacotherapy is usually not indicated in the acute stress disorder. Only the CBT is required. So the flashbacks, nightmares, dissociativeness, all this hyperarousal, vigilancy, avoidance for less than 1 month, you will call it an acute stress disorder. Okay. Any doubt?
No, thank you.
So now you know all these conditions. I have a question for you. Let me show it. Okay, read this question and please answer very carefully. I will tell you how to diagnose this condition, how to differentiate between all of these conditions. It would be a great question, okay, for you. So take your time. Answer in the chat box, okay, whenever you are ready. I got only one response so far. Please, everyone, try to response. Okay, two responses I got. Three. Two more. One more.
Actually, I've logged in from two different devices, so there are two accounts of mine.
No, there's still one remaining. I think it's Maria, I think, right? Please try to attempt. Okay. So I got all the responses. Now, let's look what the symptoms are there, right? First. So the patient is having a history of depression first. So this is the first symptom. Okay. The patient is extremely sad. Okay. Difficulty getting out of the bed. Okay. That means a fatigue you can think about. Sleeping 16 hours of day. Okay. Having an increase in the appetite. Fifth symptom. Weight gain. Okay. Low energy. Okay. Having a decreased concentration. 8 symptoms. Okay. And loss of interest. Socializing, right? So 9 symptoms of the depression this patient is having. That means I can fully diagnose it with the depression, right?
Yes.
So the patient is surely having a MDD. Now let's look if the patient is having any other mood symptom before that MDD episode. Okay. So the patient tell you that they had a similar episode, okay, at the age of 23 and 27. Okay, that means the patient is having a recurrent episodes of MDD. So it could be a recurrent MDD. Okay. Now, she also describes a brief period in the past that lasting several days, and she was uncharacteristically confident and optimistic. Okay, that means they're describing a maniac episode here, right? One symptom. Okay. Successfully juggled 3 part-time jobs. Okay, very well rested, energetic despite sleeping only for 3 to 4 hours a day. Now see, here in this scenario, the patient is either having a maniac or a hypomaniac episode. Now, how to differentiate whether she is having a maniac or a hypomaniac? It is by looking that she has successfully juggled three
Job.
three part-time jobs, right? So this episode is actually helping the patient, right?
Yes.
While in case of my maniac episode, it actually causing a distress to the patient. Okay.
Yes.
And apart from that, if you look for the history, she do not have any history of the hospitalization before, right? Before this episode,
Yes.
he
Yes.
do not have any history of hospitalization.
No.
So that means patient is not having a maniac episode, but a hypomaniac episode,
Yes.
Yeah.
right? And if the patient is having a MDD along with the hypomaniac, you call it a bipolar 2. Now, why not the cyclothymic?
2 year the seasonal.
Not the seasonal, but for a diagnosis of my cyclothymic, patient must be having symptoms for more than 2 years. In that
Yes.
case, you see all the symptoms are started at the age of 23, and now she is 29. It's been like 6 years for the patient, so more than 2. So why not the cyclothymic?
The gaps should be less than 2 months between those.
Exactly.
Yeah.
The
less than
gap should be less than 2 months. Here in this case, you can see she had the episode at the age of 23 and 27. The gap is like more than 4 years here, right?
Yes.
Not the 2 months. So if the gap is for more than 2 months, you cannot diagnose it with the cyclothymic. And plus, the patient here is fully diagnosed with the MDD, which is not a criteria for the cyclothymia. The patient must be not diagnosed fully with the MDD or fully with the maniac. She must be having a hypomaniac and not the MDD, right?
Yes.
But in this scenario, patient is having a fully diagnosis of the MDD and the hypomaniac, so goes for the bipolar 2. So now, why not the adjustment disorder with a depressive mood? As you can see, the symptoms are started, in the last month only, soon after she got a breakup with the boyfriend.
Because of a history of
2
hypomania.
months.
Yeah. Tell me.
Two similar episode.
Yeah, exactly. The presence of 2 similar episodes before. Okay. In case of my adjustment disorder, okay, there is a stressor present, and after the stressor, patient can get an anxiety, patient can get a depression, patient can get anything. But only after that episode, only after that stressor, patient should not have any history of similar episodes before.
Less
So
than
if that
6
was a
months.
patient, if that was a patient who is having this stressor present, and only after that only after that stressor, if the patient has this kind of a history, but not this present, you can get a chance of diagnosing them with the adjustment disorder. But here the patient is having a 2 similar episodes before. Okay, and plus she's also having episodes of hypomania, right? So it cannot be the adjustment disorder with depressive mood. It cannot be the bipolar one because the patient is not having a maniac disorder but a hypomaniac, right? So not a bipolar one. In the recurrent MDD, the patient is already having, as you can see, the maniac episode. So it cannot be the recurrent MDD, right?
Yes.
So count all the number of episodes patient is having and then diagnose them with any of this disorder. Okay, this will help you. Any doubt on this question?
I have one doubt.
Yeah.
How did we rule out adjustment disorder using the number of episodes?
See, in case of adjustment disorder, I told you if the patient is getting a full diagnosis of the MDD, you must diagnose them with the MDD, not with the adjustment disorder, right?
Okay, yeah. Okay.
That is the important thing. If they're getting a full diagnosis of anxiety, then you must diagnose them with the anxiety, not with the adjustment disorder. Only if you cannot diagnose them fully with the anxiety or fully with the depression, then you can diagnose them with the adjustment. Only if the stressor is present. Without the stressor, you cannot get the adjustment again.
Okay. Yeah. Thank you.
Okay. That's why I gave you this question, so that you can get an idea how to differentiate between the adjustment or the bipolar or the cyclothymia or the MDD. Okay. Now we can discuss the anxiety.
Thank you for the question.
Okay. I got this question wrong, I think 3 times in the U world. Even after my third pass, I was keep getting this question wrong. So I kind of wrote it in my notes to make sure I won't get it right, this wrong again. Okay. So that's why I got that. Okay. Now comes the anxiety disorders. Okay. In this case, a patient will have an excessive worry about a certain situation or a multiple situations. Okay. So a feeling of excessive worry about multiple situations. Okay. Having anxiety, okay, of multiple situations or as specific situations will make you a patient for a diagnosis of the anxiety disorders. Okay, let's discuss all the symptoms which are present. Okay, now before giving a patient a diagnosis of anxiety disorder, you first need to rule out the hyperthyroidism, because you guys know that hyperthyroidism is a very common cause of the anxiety. So before giving a patient diagnosis of the anxiety, you must rule out the hyperthyroidism. Similarly, before giving a patient diagnosis of the MDD, you must rule out the hypothyroidism first, because that is again a very common cause of the MDD. Substance abuses should be eliminated. Okay, the different disorders you get in the anxiety include the panic disorder, phobias, generalized anxiety disorder, and the selective mutism. Okay, let's discuss all of them one by one. So first you have the panic disorder. Okay, in the panic disorder, it can mimic anything. Okay, it can mimic a ARDS, it can mimic a myocardial infarction, it can mimic a this angina episode. Okay, it can mimic anything. You're having a sympathetic hyperactivity in the panic disorder. You will get the palpitations, you will get the neuropathies like the paresthesias, or the paralysis could be there. Depersonalization, derealization can be exist. Abdominal pain, nausea, intense fear of dying. That is the important thing. The intense fear of dying is there. Fear of losing control will be there. Lightheadedness will be there. Chest pain, choking, sweating, shaking, tremors, shortness of breath. Okay, so this condition can mimic anything, but patient will have a recurrent episodes of similar symptoms. That's how you know that the patient is not having a proper MI or a proper ARDS, but a panic disorder. To rule out other conditions, you need to do the ECG of the patient, you need to do the X-ray of the patient, you need to do the pulmonary function test, troponins level should be checked. Okay, so what the patient symptoms are presenting with, okay, you need to rule out the other medical conditions first. Only when you get all the lab tests negative, you will diagnose them with the panic disorder. Okay, the panic disorder can happen within a certain situation also only. Okay, it can happen in any of the situation. The patient will be like normal at a time, and then suddenly a minute later patient started having this panic attack. Okay, they will be hyperventilating, breathing rate will be increased, they will be having a chest pain, nausea, vomiting, abdominal pain. It could be any kind of symptom they suddenly started having. Okay, and whenever you encounter such kind of a patient who started having all these symptoms suddenly without any stressor present, without any identifiable cause present, you diagnose them with the panic disorder. Okay, and the two, three important things that were present in the panic disorder. First is a persistent concern or fear of having the additional attacks. They will always worry about the consequences of that particular attack. They think that they will die during this attack, and they will worry that what if they got another attack and someone is not there to prevent that condition. Okay, they will have a behavioral changes related to the attacks. They will start avoiding the places, the crowding places, where they think if they can and if they get the attack, they cannot escape the conditions, right? So they will get a agoraphobia because of that. Okay, they start avoiding all the socialized conditions, right? All the crowded places they must avoiding. So these are the behavioral changes present in these patients. Okay, so all these symptoms you must remember. The thing is just you will get an episode of a hyperactivity, sympathetic hyperactivity mostly. Okay, stressor must not be present for the diagnosis of the panic disorder. It can happen in any situation, any scenario. It would be a patient standing like on the bus stop and they suddenly started having this panic attack. It would be a patient in the elevator having this attack. It would be a patient drinking water and they suddenly having this attack, right? So these are the symptoms will be present in the panic disorder. And whenever you got a patient with the panic disorder, if they're having an acute attack, you will give them the benzodiazepines. And once they're stabilized with the benzodiazepines, you can give them the cognitive behavioral therapy or the SSRIs or the venlafaxine. Okay, so these are the first line therapies for the chronic use. For the acute condition, okay, when the patient is having an acute attack of anxiety, you can give them the benzodiazepines. Okay, so any doubt?
No, thank you.
No, thank you.
Second you have is the phobia. Okay, and for the phobia, okay, a specific situation must be present. Patient will get the panic disorder in a specific situation only. Like some patients are have a fear of height. So whenever they go on a very high height, they will start having this panic disorder. Some patients have a phobia of the elevator. So as soon as they see the elevator, they started having the panic attack. So whenever an identifiable stressor is present, and because of that the patient is having a this attack, you will call it a phobia, not a panic disorder. In that case, no drug therapy could work. The only therapy would work is the CBT. Okay, and the symptoms must be persistent for more than 6 months. So if the stressor is present, it is phobia. If the stressor is not present, it is the panic disorder. Any doubt?
No, thank you.
No.
Now you have the social anxiety disorder. You will get the anxiety only in the social situations, like speaking in the public or getting interaction with the public. So the patient will always avoid the social interactions. In this case, they will always have a fear of the embarrassment. Okay, they will always fear what others would think about them. They will feel very embarrassed talking to the others, and that is the social anxiety disorder. So they cannot go in the public, they cannot meet new person. Okay, they will always about meeting new persons or getting into the crowd. Okay, treatment include the cognitive behavioral therapy, SSRIs, venlafaxine. Okay, if they ask you a specific treatment, it will be the CBT. If the CBT is not there, SSRIs, SNRIs could be given. Okay, whenever a patient got an acute attack of anxiety, beta blockers can also be used. You have the agoraphobia, which is a consequence of the of this panic attack. Okay, whenever the patient is having a panic attack, they will always fear of the crowded places, because they think that in a crowded place, if they get the panic attack, then they cannot find the escape. In that case, they will always avoid the crowded places, the public transport, or the closed spaces, and that causes the agoraphobia. So a patient with the panic disorder can get the agoraphobia. Okay, and all this, the patient is avoiding the crowded spaces or the public spaces, both in the agoraphobia as well as in the social anxiety disorder. So how can you differentiate between the SAD and the agoraphobia? Tell me. In both the conditions, you're avoiding the public places or the crowded places or interacting with a uh, new person. So how will you differentiate between the SAD and the agoraphobia?
In social anxiety disorder, I think you are avoiding being embarrassed. That is your biggest fear of judgment of.
Yeah, exactly. Or in agoraphobia, you're avoiding your panic attack in the public spaces. So when the anxiety is because of this panic attack, having the fear of panic attack, it is the agoraphobia. If the anxiety is because of the embarrassment in the public places, it is the social anxiety disorder. Okay.
Okay, yeah.
Okay.
Then you have the generalized anxiety disorder. Now, up to here, what we have discussed, all the anxiety in a specific situations. In case of generalized anxiety disorder, no specific situation is present. You will get the attack of anxiety in multiple situations. Patient will have an excessive worry about different aspects of daily life, like work life, like the social life, and the kids, okay, and the family. They have excessive worrying about all the kids, husband, okay, their work, okay. And whenever you encounter such kind of a patient, okay, they cannot sleep because of these anxieties, because having this worry, they cannot sleep, they become very much irritable, they will become very much fatigue because of lack of sleep, okay, they have difficulty concentrating, okay, while working, while doing anything, they have this kind of a thoughts, okay, of these anxieties, that what if something wrong happened to the kids, how will the kids manage their homework or their school life, right? So having a multiple uh, having this anxiety in the multiple aspects of the life, and as a result having this fatigue, sleep disturbance, irritability, tensions, headache, all these things, it will make a diagnosis for the generalized anxiety disorder. Please note, the symptoms must be present for more than 6 months. Okay, stressor could be there, could not be there. Okay, 3 symptoms at least must be present. Okay, and treatment again includes the CBT, first line therapy. If not the CBT, it will be the SSRIs, SNRIs. Okay. Other atypical antidepressants like the buspirone, TCAs, benzodiazepines could be also be used as a second line therapy. Okay. Patient can also have the physical manifestations of the symptom, like the abdominal pain or the irritability. Because of that, headache could be there. Okay. So a marked functional decline must be present. Patient cannot enjoy their daily life. Patient cannot properly focus on their work life, right? They have a difficulty in the concentration, they have a poor performance because of that. Okay, so having a functional decline is must in case of my generalized anxiety disorder. Any doubt?
No, thank you.
No.
Okay, now you have the obsessive compulsive disorder. As the name suggests, first you have the obsessions, some thoughts, some recurring intrusive thoughts. To satisfy these thoughts, patient do this compulsiveness. They will do some activity, okay, to satisfy their thoughts. Okay, it could be an obsession with the symmetry. Okay, it could be an obsession with the fear of germs. It could be an obsession with some kind, of fear of getting a damage. Okay, a fear of getting a blast. Okay, a fear uh, of getting robbery. Okay, so it could be fear of anything. Okay, they will have these intrusive thoughts. Okay, like if they do not check their stoves regularly, they can have a gas leakage. If they cannot check they are locked properly, then they can have a robbery, right? If they do not wash their hand properly, they can have a germs. If they do not make everything very much symmetrical, then they can have something wrong. So these kind of thoughts will be there, and because and in order to satisfy these thoughts, in order to get a relief from these thoughts, patient do the compulsions. Okay, they will do the repetitive knob checking. They will do a repetitive checking of the gas stoves. Okay, they will make everything symmetric, their hair. Okay, they will cut every vegetable in a very symmetric way, right? So that is the obsessive compulsive disorder. Patient, all these activity must be time consuming. Okay, these activity must consume at least 1 hour of their day. They will spend 1 hour washing their hands, 1 hour checking their doorknobs, 1 hour checking their stoves, 1 hour checking their symmetry, cutting everything in a very symmetrical way. Okay, so the activities must be time consuming. and they will decreases the performance of the patient. They must not be helping the patient in their goals, right? They must be declining the performance of the patient. They must be keeping the patient away from getting their goals, right? So these are the obsessive compulsive disorder. It can be associated with the Tourette syndrome, as we have discussed previously. Treatment include the SSRIs, okay, chlorpheniramine, CBTs, venlafaxine could be given, okay, and yeah, that would be about my obsessive compulsive disorder. Any doubt?
No, thank you.
No, thank you.
Now, the second, in sometimes, Esteban can describe you a patient who is having a history of excessive grooming. Okay, she need everything to be very much perfection. Okay, nail polish or their her hairs. Okay, and she need everything to be very much symmetric. She cuts all the vegetables in a symmetric way, and she will tell you that and when you ask why she is doing all these things, she will tell you that she has this fear that if she do not do such kind of a things, then something bad might happen. And because of this fear of getting something bad will happen to them, because of this fear, they will do all these activities, and you will diagnose the patient with the obsessive compulsive, because the excessive grooming could be present in case of body dysmorphic disorder. This excessive mirror checking and excessive grooming could be present in the eating disorders also. Okay, but the fear of something bad might happen, this fear will make you a diagnosis of the obsessive compulsive, not the other conditions. Okay, not getting my
Okay.
point?
Yes.
Okay, so excessive mirror checking could be present in any other disorders also. Excessive grooming could be present in any other disorders also. But excessive grooming or excessive mirror checking, because of this fear, it will make your diagnosis of the OCD. Then you have the body dysmorphic image disorder, in which the patient have, although the body of the patient is totally normal, okay, but in their eyes they see a defect in any of the part of their body. It could be a thigh, it could be a hand, it could be their face. Okay, so preoccupation with a minor defect in their appearance on any of the body part, and because of that, they will have the emotional distress. They will avoid the public places. Okay, they will avoid the social interaction because of that. Okay, they will have a repetitive grooming. Okay, repetitive mirror checking would be there, right? It will make a diagnosis of the body dysmorphic image disorder. They have a concern about their appearance. They will brush their hairs multiple times a day, something like that. Okay, so in the body dysmorphic image disorder, patient will feel disgust about a particular body part. They will have a normal BMI. Okay, because in case of my and so because of this fear, because they think that they have this ugliness in their body part, they will do fasting, they will lose their body weight, they will exercise very excessively. So you can sometimes confuse it with the other eating disorders like the anorexia or the bulimia nervosa, right? But please note, in case of my bulimia or the anorexia nervosa, patient will have a fear of the weight gain, and because of that, they will do all these exercises and the fasting. In case of my body dysmorphic image disorder, they have a preoccupation about a particular body part, about a dysmorphic image of a particular body part. So in that scenario, they will do all this fasting and the exercise. Okay, they will always feel that they look very disgusting, right? So they will avoid all these social interactions because of that. Okay, so they may concerned about the body weight, but not as much as in the anorexia nervosa or the bulimia nervosa. So please note, if you encounter a patient, okay, you will have to differentiate between the anorexia, bulimia, and the body dysmorphic image disorder. Okay,
Yes.
that was about it. Then you have the trichotillomania, okay, in which patient get compulsions of pulling out the hair. Okay, they will pull out their hair, it will make them bald. Okay, and as you can see, all these lesions the patient get, they are very much kind of well demarcated lesions. Patient can even get a loss of complete hair on their body. Okay, the only way by which you can differentiate it with the other causes of alopecia, like any fungal cause, Okay, for example, because in case of a fungi, you can have a very demarcated lesions of hair loss, right?
Yeah.
Yes.
So in order to differentiate with the other conditions of the alopecia, other causes of the alopecia, you must look for the hair growth of the patient. If all the hairs are in a different stages of the development, some hairs are thin, some hairs are thick, some hairs are long, some hairs are short. So if all the hairs are different stages, you will diagnose them with the trichotillomania. If all the hairs are in the same stage, if they have a same size, same thickness, then this alopecia, this loss of hair is because of the fungal infection. Okay, because patient pull out their hairs at a different time, so all the hairs will be present in the different stages, right? All the height, the thickness of the hairs will be varying. They have irregular patches. Okay, irregular patches can be present in the fungal infection also, but in the fungal infection you will have a same hair length, same hair size. Okay, any doubt on the trichotillomania?
No, thank you.
So that was about all the panic disorders, anxiety, and all these OCDs on this page. Any doubt, please ask on this page.
No, thank you.
Then you have the diagnosis criteria, certain time durations for certain diseases. Okay, we are yet to discuss the narcolepsy, so just forget about it. For childhood disorders, I told you that every childhood disorder you will only diagnose after the 5 years of age, right? For the selective mutism, you need at least a 1 month history. For the separation anxiety disorder, you need at least a 4 week history. That means around a month again, right? For the panic disorder, you again need a 1 month history. For the specific learning, you need 6 months. ADHD, you need 6 months. Oppositional defiant disorder, you need the 6 month. Okay, for the Tourette syndrome, you need 1 year history. For the disruptive mood dysregulation disorder, you need a 1 year history. For the anxiety disorders, you will call it an acute stress if the symptoms are present in less than 1 month. You will call it a panic disorder if the symptoms are present for more than 1 month. A PTSD for more than 1 month. You will call it a phobia if the patient is having anxiety in a specific situation for more than 6 months. You will call it a generalized anxiety disorder if the symptom is present for more than 6 months. If the symptoms are present for less than 6 months, you will call it a adjustment disorder. For the mood, you have the major depression for 2 weeks. Okay, maniac or the bipolar for 1 week. Schizoaffective disorder for more than 2 weeks. Okay, and schizoaffective, more than 2 weeks of the psychosis without the depression or without the mania. Delusion disorders for more than 1 week history required. Brief psychotic, less than 1 month. Schizophrenia from less than 6 months. After 6 months, it will be the schizophrenia. A complicated grief will be more than 6 months, or you can say more than 12 months, not the 6, but a 12-month history is important. Okay, dysthymia more than 2 years, cyclothymia more than 2 years. Any doubt?
No, thank you.
Hi, I had one question. It's selective mutism. Is there like a certain age after? Is that like again after only 5 years you can diagnose it?
Only after 5 years only after 5 years you can get a diagnosis, because up to the 5 years the patient is still in the developmental milestones, right?
Okay. Okay.
So only after 5 years, when the developmental milestones are achieved, if the patient is lacking at some places, you will call it a selective mutism.
All right. Thank you.
Yeah. Then you have the personalities. Okay, everyone, each of us has a personality trait. Okay, some of us are happy, some of us are kind of having very much high humor. Okay, some of us having a short temperedness, right? So all of us having a personality trait. It will become a personality disorder, okay, whenever it become very maladaptive type. Okay, whenever it is causing a stress to the patient, a distress to my patient, I will call it a personality disorder. Okay, please note, up to the 18 years, the patient is still developing, any person is still developing the personality. So before the 18 years, I cannot diagnose them with any of the personality disorder. Only after the 18 years, when a person acquired one of the personality, I can diagnose them with the personality disorders. Okay, so if you encounter in the clinical vignette any patient who is having an age less than 18 years and the options mentioned any personality disorder, you can directly eliminate it by looking at the age of the patient. Okay. Yes. Then you have three clusters: the cluster A, cluster B, and the cluster C. Okay, cluster A, you can remember it by the patients are kind of very much weird. In the cluster B, the patients are wild. Okay, like in case of antisocial personality disorder, they are very much wild. Okay, they will attack on others. In case of cluster C, they're very much worried about themselves, about their relationships. So first you have the cluster A personality. Okay, and in that case you have three disorders. One is the paranoid, second is the schizoid, and third is the schizotypal. Okay, so for the paranoid personality disorder, the patient have just like the delusion, a fixed false belief, right? They have a the pervasive distrust about their partner. Okay, they have a suspiciousness. They have this hyper vigilance about their partner, that their partner is unfaithful to them. Okay, their partner is cheating on them, and no matter how many evidences you give, the patient still believe their paranoid delusions. Okay, and the hallmark ego defense is the projection. Any feeling the patient is having for their partner, they will project that feeling onto the partner itself. Okay, they will tell that the patient or the partner is thinking the same thing about them. Okay, that is my paranoid personality disorder. Then you have the schizoid. Okay, in the schizoid personality disorder, they chooses the social isolation. They do not enjoy the company. Okay, they want to be alone, and that is an important thing. They have a very limited emotional expression. They chooses the social withdrawal because they do not enjoy the company. Okay, they do not have any close friend. They always avoid interacting with the others. Even if someone try to approach them, they will just ignore him. Okay, so this is the schizoid personality disorder. Then you have the schizotypal personality disorder, in which the first thing is the eccentric appearance. They will have a very improper type of clothing, like in an office settings they wear a cowboy dress. Okay, in the parties they wear a very formal dress, for example. Okay, in the hospital they wear a joker dress. So they have this eccentric appearance. Okay, they always wear clothes which are very much kind of different than with the surrounding, right? They have few close friends. Okay, but and just like in case of my schizoid, okay, they do not have any kind of friend. In case of my schizotypal, they have some close friends. Okay, they always have a magical thinking, like unicorns or like some magical healing powers. Okay, so they have a magical thinking. The patient believe in the telepathy, sixth sense, or magical healing powers. They do not have any hallucinations. They do not have any disorganized speech or behavior. Okay, so you cannot diagnose them with the schizophrenia. That is an important thing. Okay, they have the disheveled look just like my schizophrenia. They have a poor hygiene. Poor oral hygiene will be there. Okay, improper dressing style will be there, right? And they think that they have this secret conversation with the TV partner, like some kind of a news. If it's in the TV, they will tell you that the news is about them. Okay, so these kind of a beliefs will be there in case of my schizotypal. So a very odd person who is odd to the surrounding, think about the schizotypal. A person who is very socially isolated, do not enjoying the company, think about the schizoid. A patient who is very kind of having a distrust about other persons, even the physician, think about the paranoid. Any doubt?
No.
Why the personality disorder cannot be diagnosed before age 18?
Because up to the age of 18, the patient or the person, any person, even us, are still developing their personalities.
Is that because the frontal lobe not mature completely until then?
Yeah, exactly.
Okay, thank you. Thank you.
Now comes the cluster B, and they are very much wild patients. Okay, the first one is the antisocial. All these patients are involved in the criminal activity, like a dog fighting club or selling drugs. Okay, or killing someone or break failing or setting fire in some places. Okay, they all have a vindictive behavior, which means a revenge seeking behavior. They are involved in the stealing objects or money. They do not have any remorse of any person. Okay, and they always blame others for their behavior, that that person deserve what has been done to them, right? So no remorse. Okay, blaming others, revenge seeking behavior, criminal activities. Think about the antisocial personality disorder. Before the age of 15, you will diagnose a patient with the conduct disorder, right? And after 18, antisocial. Okay, most of the patients who are diagnosed with the antisocial, they have a conduct disorder before the age of 15 years. Okay,
Yeah.
that was about the antisocial. Treatment include the dialectical behavior therapy. Then you have the borderline personality disorder, and I told you about the splitting behavior, remember?
Yes.
Either a particular person is too much good or a particular person is too much bad, not in between for them. Okay, they always have an unstable kind of mood in a relationships. They always suffer, they always have a problems in the relationship, because their partner, at a one time their partner is so much loving, caring, and in one time for them, okay, in their mind, for these patients, their partner will become very much unfaithful, very much unfair to them, right? So they always have a intense mood swings since the adolescence. It is most commonly seen in the women. So they always have a interpersonal relationship problems. They have a fear of the abandonment. They have a suicidality. Okay, they have a impulsivity. Soon after the breakup, they start indulging in some kind of a sexual activities or gambling or traveling without thinking of the consequences. This thing is there in the borderline patients. They have a self mutilation. Whenever you encounter such kind of a patients, it always because of the suicidation. Okay, it is always because of a suicide case. Most oftenly they seek the medical attention due to the suicidal behavior, and they will tell you that their partner is not faithful to them, their partner is kind of very much unfair to them. Okay, so at one time they have a very great friends, and then the later day they have, the same person, they start hating them. Okay, they have a very intense fear of abandonment, accuses other for the fear of abandoning them. They have a impulsivity. They may go on spending having sex with the strangers, or recklessly driving, having gamblings, or you know uh, or traveling without thinking about the money problems. Okay, that is about the borderline personality disorder. Any doubt?
No, thank you.
No, thank you.
Now, for the histrionic personality disorder, think about the person who always want the attention of others, and to gain that attention, they can do anything. Okay, they wear some kind of inappropriate type of clothes. Okay, sexually provocative clothes they can wear. They will talk very loudly. Okay, they smile very inappropriately. Okay, so they can do anything to get attention of the others. They always want to be the center of attraction. Okay, think about the histrionic personality disorder. Okay, they always want the relationship to be too much romantic. Okay, they already have a romantic relationship, but they want it to be much more romantic than what it is now. Okay, these are the histrionic. Any doubt?
No,
No,
thank
thank
you.
you.
Then a narcissistic personality disorder. Okay, think about the person, okay, who think that he's a superior among the others. Okay, they have this grandiosity. They are that they are very much superior, very much great than the others. Okay, they have a sense of entitlement. They lack empathy, just like my antisocial personality disorder. They have a lack of empathy for others. They think that whatever is happening to them, it is their fault, they deserve it. Okay, they always have a competitive kind of behavior. They always want to compete the others for the superiorness, and whenever they realizes that they are not superior than others, they always feel very depressed, very sad about it. Okay, they always react to the criticism whenever someone tell them that they are not good, that they are not best. Okay, and that whatever they are doing is not good, they always try to defend themselves. Okay, they have this defensiveness. I think everyone has watched Iron Man, right?
Yeah.
In the Iron Man, he has this narcissistic personality disorder. Okay, think about the
Yeah.
Iron Man.
Yeah.
They always want, they always think that they are superior. They always, react to the criticism, right? So that was about it. So they assume that they are brilliant. Okay, they want, or they think that they deserve very special treatment. Okay, they are preoccupied with the fantasies of the ultimate success. In case of my histrionic, they want the fantasies of the relationship to be more romantic. In case of my narcissistic, they always have a fantasies of being a superior than the others, of having a success. Okay, they fantasize about their intelligence, about their beauty, and all these things. And as soon as they realizes that they are not the best, they will feel very depressed about it. They always want to hear that they are best, right? That is the narcissistic personality disorder. Any doubt?
No. Thank
No,
you.
thank you.
Then you have the cluster C personality disorder, and these patients are very much worried about themselves. They have, they're extremely anxious and fearful about their relationships or about their interactions. One is the avoidant personality disorder. In this scenario, patient, again, just like my social anxiety disorder, avoid the social interactions. They have a feeling of inadequacy. Okay, they have a feeling that they're inadequate for the others. They have a fear of criticism, fear of embarrassment, fear of inadequacy, fear of it being judged, fear of rejection. Okay, they don't want that, someone reject them. They don't want that someone judges them. They always have this fear, and because of that fear, they always avoid the interaction with others. So tell me, in both the conditions, you're avoiding the social interactions. The patient is avoiding the social interactions. So how can you differentiate between the social anxiety disorder and the avoidant personality disorder?
In social, the person is voluntarily avoiding the situation. He doesn't want to join.
Now, in both the conditions, they're avoiding situations because of the fear.
Schizoid.
No, not the schizoid. I'm asking about the social anxiety disorder and the avoidant personality disorder. In both the conditions, I'm basically avoiding the social interactions, right? So how will you differentiate between the avoidant personality disorder and the social anxiety disorder?
Relationship,
What about relationship?
like
Avoid
in
and they like.
avoidance.
In both the
Yeah.
conditions, they avoid the relationship because they avoid the interactions, right? They don't want to interact with others. So they will avoid all these relationship things.
Would avoidance be at least social people have a core of people that they are okay with versus avoidance avoid everything?
Sorry, repeat it again, please. I couldn't hear you.
The avoidance avoid react to everyone and everything's like everyone's criticism versus the social anxiety disorder. People have a core group that they are okay with.
Well, sometimes the avoidant persons can have some close friends that they're okay with, like the mother maybe, or like some sisters, siblings. So they both can have a core group which they're okay with. Any other point? See, in case of my avoidant personality disorder, patient wants a relationship, but they just had the fear that they are, kind of insufficient to their partner, inadequate to their partner. They have a feeling that their partner will judge you, that their partner, whenever they try to approach someone, they will reject them. They don't want to talk to them. Because of this fear of inadequacy, judgment, rejection, criticism, they avoid all the interactions, they avoid all the relationships. All they fantasize about having a romantic relationships, but they cannot have it because of their fears. In case of my social anxiety disorder, person is avoiding a social interaction because of the fear of embarrassment. Okay, that they might say something which may embarrass them, that their appearance might embarrass them. Okay, that they are very much inferior to others, you can say. Okay, that is a huge difference between the avoidant personality disorder and the social anxiety disorder. Okay,
I couldn't understand. Could you please explain it once again?
In case of my avoidant personality disorder, they're avoiding the situation because they think that other persons don't like them.
Yeah.
Okay, they're not like others, they're inadequate for them, they might judge them about their appearance, they might reject them, right? In case of my social anxiety disorder, the patient is avoiding the situations, social interactions, because of the fear of embarrassment, that they might say something that might embarrass them, that their clothes might embarrass them, that their body might embarrass them, anything it could be. So they have a fear, that they're inferior to others. In case of my social anxiety disorder, they do not fantasize about relationship at all. In case of my avoidant personality disorder, they fantasize about having a relationship, but they cannot have it because of their fear. It would be a patient who is having a age of like 35 or 40 years old, and she still is single. She do not have any boyfriend, or she's not married still. Okay,
Okay. Yeah. But thank you.
that is a huge difference. The reason why they're avoiding the social interactions, this is a very important thing. Having a fantasy about the relationship is an important thing. Okay, then you have the obsessive compulsive personality disorder. So in the very initial, I told you about the obsessive compulsive disorder, and now we are talking about the obsessive compulsive personality disorder. Okay, in case of my obsessive compulsive personality disorder, I'm doing some things, okay, which are taking me towards my goal. Okay, I'm making plans. Okay, I'm doing everything according to that plan. Okay, I'm very perfection. Okay, I'm having a very preoccupation with the perfection. Everything I want it under my control. Okay, so everything they do, it will take them towards their goal. While in case of my obsessive compulsive disorder, because they're doing some activities which are wasting their time, those activities were keeping them away from their goal, right?
Right.
But in case of my obsessive compulsive disorder, I'm making plans, I'm making timetables, I want everything to be perfect, okay, in order to take me towards my goal. That is the obsessive compulsive personality disorder. Then you have the dependent personality disorder, in which in this condition the patient is dependent on their partner for everything. Okay, they even might get a physical abuse, okay, with their by their partner, even though they cannot leave the patient and the partner, even though their partner is abusing them, they cannot leave it because of because they are dependent on their partner. They have a very low self-confidence, they need excessive support from their relationship, right? And every time, most of the time, these kind of a patients, they stuck in the abusive relationships. Okay, so it would be a patient who is suffering from a domestic violence, but still they cannot leave their partner because of their fear. Okay, they have a low self-confidence, they are totally dependent on their partner for everything. That is the dependent personality disorder. So in all of these clusters type C, you're having a worried patient. Okay, in cluster type B, I'm having a very wild patient. In cluster type A, I'm having a very weird patient, right?
Yes.
So now, any doubt about any of the cluster personality disorders, cluster A, B, C?
No, thank you.
So in order to remember all these symptoms, all these, all the presentations of the patient, you must imagine a patient first in your mind. Imagine a video of a patient, okay? And then try to differentiate all of these conditions with each other. You will get an idea how to diagnose all these conditions, okay?
Okay, yeah.
So now I think we should stop here for now. Okay, and from tomorrow we will discuss all the Malingrin's, factitious disorder, and we'll finish the psychiatry tomorrow. Okay.
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 Thank you so much.
Thank
Thank
you.
you everyone for joining.